Ποια? 52... Έβαλε τίτλο. A 52 year old.
Πού το κατέβασα εγώ άμα το κερατάκι μου. Τώρα πλέον είμαστε live κι εγώ φото.
Πώς?
Η ώρα 9.
Σε 4 λεπτά.
Σοβαρά.
Οπότε, ξέρεις.
Έλα βοήθα με ρε.
Τώρα να κατεβάσεις τις μαλακίες εδώ, ρε.
Αυτό το λάπτοπ για τη σχολή.
Ναι.
Πώς θα τα κατεβάσω των άλλων όρια. Κάπου τα κατέβασα και κάπου πήγαν στο σύμπαν και τα...
Δεν έχεις. Γάμισε.
Good morning, everyone. Thank you all for coming. We're sorry about this small delay. I want to officially thank you for coming to the free papers session for CAMeSM. We are very grateful for your contribution. And we are also very, very excited that this year we are both including presentations and posters as well, which will be available during the break at 1 and 2 p.m. So I would like to first welcome the speaker, Maria Elisa Kontogianni, and her colleague, Katerina Mazzarini, with their presentation on the advancement of male contraception.
Sorry. Okay, good morning, everyone. So today my colleague and I are going to presenting a promising step towards reversible male contraception, the testosterone transdermal gel. Over here is what we're going to talk about today. So let's begin with some statistics. An interesting fact is that approximately 45% of pregnancies worldwide are unintended. And to put that into perspective, that's approximately over 120 million unwanted pregnancies. Another fact is that a systematic review revealed that approximately 43 to 94% of women were willing to rely on their partners for a novel male contraceptive method. Also, a global survey indicated that 88% of men would take male contraceptive pills instead of relying on their partner. We're going to move on to a brief overview of the female and different male contraceptive methods. So, currently, most contraceptive methods and their burdens fall on women. There are over a dozen, as we can see over here in this figure, contraceptive options like hormonal, barrier, or permanent, and they all come with side effects. For example, in this table we can see the different methods, types, effectiveness, and duration of some of the contraceptive methods. We can also see, for example, hormonal pills, IUDs, implants, and injections. And this is a very famous picture of the little paper inside the box of the pill with the different side effects. And I would just like to highlight a few. For example, women might suffer from irregular bleeding, decreased libido, long-term hormonal disruption, increased risk of blood clots, stroke, heart attack, and different types of cancer. And here we see the 3 different options for males. We have condoms, vasectomy, which is irreversible and permanent, and withdrawal. The reality is that women carry most of the physical and emotional stress and the side effects. That's why developing a male alternative is so important. Now I will pass the floor to my colleague Katerina.
Okay. Sorry, I'm shorter. Okay. So, I would like to begin with an overview of spermatogenesis. This is a process by which sperm cells are produced in the seminiferous tubules of the testes. So, it starts with diploid spermatogonia, which undergo mitosis and consequently meiosis, which then to produce haploid spermatids, which then will mature into spermatozoa. This process is highly organized and supported by the Sertoli cells, which provide structural and nutritional support. Importantly, spermatogenesis is a continuous process. It begins in puberty, and it is regulated by a complex hormonal interplay, which I will cover in the following slide. So, what happens here? Spermatogenesis is primarily regulated by the hypothalamic pituitary gonadal axis, or HPA axis. The hypothalamus secretes GnRH, which will then stimulate the anterior pituitary to secrete FSH and LH. More specifically, LH acts on Leydig cells inside the testes, promoting the production of testosterone. Testosterone will then act on Sertoli cells, which is essential for spermatogenesis. FSH, on the other hand, acts directly on the Sertoli cells, stimulating them to support sperm development and produce androgen-binding protein, which will help maintain high concentrations of testosterone in the testes. Together, this tightly regulated process ensures optimal sperm production. So, now based on the pathway I just explained, let's consider a therapeutic approach to male contraception. The general idea here is to design a drug that interferes with the pathway I just described to you, specifically to inhibit FSH and LH production. By doing this, we reduce the stimulation of Sertoli cells and Leydig cells, which will lead to decreased testosterone production and diminished support for spermatogenesis, ultimately resulting in reduced or halted sperm production. The key challenge here is to achieve sufficient suppression, but without causing side effects, such as libido loss or long-term hormonal imbalance, which can obviously lead to secondary effects. So, let's take a look at an actual drug approach that relies on the concept we just discussed, suppressing LH and FSH to reduce sperm production. So one promising formulation is the Nest gel, which is a combination of nesterone, which is a progestin, maybe you've heard of that before in female contraception, as well as testosterone. Nesterone works by suppressing both LH and FSH secretion directly from the pituitary, which in turn reduces stimulation of the testes and leads to decreased endogenous testosterone. To counter the loss of testosterone, we still want to maintain the secondary sex characteristic of males. Testosterone is also co-administered in the gel. It restores the systemic testosterone levels, presents muscle mass, sexual function, and overall well-being, while still keeping intratesticular testosterone low enough to suppress sperm production. So, how is this delivered? This gel is delivered transdermally. This means it is absorbed through the skin. So you just put the gel on your skin and it's absorbed. This method offers several advantages. It provides steady hormone levels, it avoids the first pass metabolism by the liver, and it is non-invasive, making it more acceptable and user-friendly. Only about 10% of the total dose is absorbed, but this is sufficient for hormonal suppression. Importantly, the effects of the gel are reversible. So, once a person stops using it, LH and FSH secretion resumes, and sperm production typically returns to normal within a few weeks to months. This makes it a promising option for male contraception, effective, manageable, and reversible. This is about transdermal delivery.
So now we're going to move on to an actual clinical trial. Sorry, I'm taller. So this was a phase 2b trial with approximately 462 male participants and their female partners from 8 different countries. It included a 20-week suppression phase, a full year of contraceptive use, and a 6-month recovery phase. The participants were healthy monogamous couples. Men had normal sperm counts, women had regular menstrual cycles, and no known fertility issues. Regarding the gel composition that was administered, there was 8 micrograms of nesterone, 74 micrograms of testosterone. This together is 5 microliters of a daily dose, and it was applied transdermally, like Katerina explained, in each shoulder blade. The primary goal was sperm suppression. Secondary measures included hormone levels, safety, sexual function, and pregnancy rates, and also partner exposure. Moving on to the results, regarding sperm suppression, it was 89% of men achieved effective sperm suppression, which was less than 1 million per microliter. It was efficacious, especially the combination of nesterone and testosterone compared to testosterone alone. It had minimal side effects, for example, acne, weight gain, and mood changes, which should be expected since it's a hormonal approach. And there were no significant hormone transfer to the female partners, reinforcing that this method is safe for both of them. There was high satisfaction, acceptability, and recommendation rates among male users. This is one of the largest trials of its kind, showing that men are capable of managing a daily contraceptive and women are willing to rely on it. And unlike most female methods, the Nest-T gel is reversible, non-invasive, and doesn't alter long-term hormonal balance. It also tracks adherence, is the first to use validated tools to monitor mood and sexual function. It included participants from Africa, expanding the diversity of the study population. However, there was a limitation that there was no placebo or binding. However, that would be unethical in a contraceptive trial.
So, while the results are exciting, there are obviously many hurdles to overcome before this product can be brought to the market. First of all, there are no FDA guidelines for male contraception yet, which slows the regulatory approval. Additionally, there is no pharmacological partner at the moment, and it is estimated that the cost of getting this out to the market will be around $2 billion, which is a lot. Also, we still need around 5,000 participant years of safety data before approval is possible. Overall, the future of male contraception is looking much more realistic, and the Nest-T gel is leading the way so far. Thank you very, very much.
Also over here, if you're interested, we have a QR that if you scan it, you can see an ongoing clinical trial, and men can also participate. Thank you. Are there any questions, maybe? Yes.
Are there any other contraceptive methods that are currently in clinical trials?
Well, because we did the research, we were interested in the whole concept. It was something that we didn't know existed, so we decided to search. And from what I remember, there were two that sounded more promising. There was something called Plan A instead of Plan B. Yeah, it's an orally administered contraceptive method, and there was also a gel that you inject in the vas deferens, a hydrogel. I don't remember the name of that, but that's as far as I know. Do you know anything else? No. Yeah.
There was obviously much less data on male contraception versus female contraception, but this was the most interesting and most promising so far, so I hope you enjoyed it.
Thank you.
Okay, great. So, thank you very much, girls, for the interesting presentation. Now we're going to hear about brain aging, mechanisms, and prevention from Rodothea Savidi.
So first of all, let's start with what is aging. Well, aging is a biological process where we have this accumulation of cellular and molecular damage over the years. As the time is going to pass, the body will be unable to repair this damage, so it's going to lead to the loss of physiological functions. As we age, the brain also is going, with that being said, the brain is not really immune to those effects of aging. So it's going to undergo atrophy, where lower white matter volume and aberrant functional connectivity are actually the most prevalent age-related changes. Moving on to the structural ages, and as the brain ages, is going to undergo some morphological changes. Those include cerebral atrophy, gray and white matter changes, volume loss, ventricular enlargement, and sulci widening. It should also be noted that its volume and weight will decrease 5% per rate after the age of 40, and that the rate is going to significantly increase after the age of 70. When talking about changes in the gray matter, there's also going to be a reduction in the dendritic aberration complexity. Specifically, there's going to be the dendritic shortening and decreased dendritic spines. So as a result, it's going to cause progressive reduction in the synaptic density and transmission, and as a result, you're going to have cognitive decline. Changes in the white matter include partial loss of myelin, axons, oligodendroglial cells, and reactive astrocytic gliosis. As the people age, the groove and the faults in the cerebral cortex, sulci, and gyrus, respectively, are going to get shallower and wider. The blood vessels in the brain will also be affected, meaning that there going to be arterial inflammation and arteriosclerosis. Those elastic fibers, the collagen, the smooth muscle cells are going to deteriorate over time. So now let's move on to the cellular and molecular hallmarks of brain aging. And starting off with mitochondrial dysfunction. With aging, there are some numerous changes that were observed in mitochondria. Those include the enlargement or fragmentation, increased oxidative stress to the mitochondrial DNA, impaired calcium handling, and a lower threshold for triggering the formation of mitochondrial membrane permeability transition pores that are responsible for that are important in apoptosis. There's also the accumulation of oxidatively damaged molecules. Specifically, we have this dysfunction, aggregated proteins and mitochondria are going to accumulate in the neurons due to the oxidative imbalance, meaning we're going to have increased production of reactive oxygen species and a low antioxidant defenses. There are going to be increased levels of superoxide anion radical, the hydroxy radical, and nitric oxide. All of these are going to cause impairment in the membrane proteins, which are essential for cell metabolism and survival. Next, there's also impaired lysosome and proteasome function. The lysosome and proteasomes, they are responsible for the removal of damaged organelles and molecules through autophagy and degradation, respectively. So with brain aging, autophagic and proteasomal degradation is going to be impaired. We have the 4-hydroxynonenal, which is a product of lipid peroxidation that is associated with the amyloid deposits and neurofibrillary tangles. Those can disrupt the lysosomal function in the cerebral cortical lesions, so it's going to lead to a buildup of cargo and eventual cell death. Furthermore, there's dysregulation of the neural calcium homeostasis. So the calcium ions, they're responsible for the regulation of neural function and structural adaptations of the neural networks. It was shown that with brain aging, they're going to have the impairment of the calcium-induced hyperpolarizations. That is going to increase the calcium influx through the calcium channels, thus increase the calcium release from the endoplasmatic reticulum. The calcium channels and that increased levels of the calcium release from, this is going to lead to an elevation of the cytoplasmatic calcium ions and dysregulation of the protein phosphorylation, gene expression, and cytoskeletal dynamics. Another mechanism is the compromised adaptive cellular stress responses. The neurons, they're under metabolic, ionic, and oxidative stress from the normal electrochemical activity and the extrinsic factors. There are some pathways that are going to respond to that cellular stress in order to alleviate that threat. Now, the most important initiators of those adaptive cellular stress responses are actually the ATP consumption, calcium, and reactive oxygen species. But those pathways that can alleviate the threat, they can become impaired during aging, and the neurons are going to become more vulnerable to injury and neurodegenerative diseases. Next up, we have the aberrant neural activity. During brain aging, the neural network activity in the brain is going to be disturbed. So they have the GABAergic signal is going to be impaired, causing excitatory imbalances. This is also caused by oxidative stress, mitochondrial dysfunction, impaired adaptive stress responses, and inflammation. Next, we have the impaired DNA repair. The ROS is going to damage the DNA in the nucleus and the mitochondria throughout aging and normal cellular function. In the neurons, this damage is going to be exacerbated after the excitatory synaptic activation. We have the coordinated actions of proteins in the DNA repair pathways like homologous recombination, mismatch repair, and nucleotide excision repair, as well as the base excision repair, which all of these are going to quickly eliminate that damaged DNA bases and replace them with undamaged bases in healthy young cells. During aging, though, we're going to have an increase in the damaged mitochondria and mitochondrial and nuclear DNA, as well as a decreased expression and enzymatic activities of the DNA repair proteins. Inflammation is also another hallmark of brain aging. In the aged brain, it was noted that the glial cells, specifically the microglia, are in an active state, meaning that we're going to have the production of pro-inflammatory cytokines. This is going to lead to synaptic degeneration and impairment of the brain function. Next, there's impaired neurogenesis, where in the normal aging there are going to be reductions in the hippocampal and olfactory neurogenesis that are going to lead to cognitive and olfactory deficits. As we age, the telomere shortening and senescence occur in the mitotic cells all over the body. So with each round of cell division, the telomeres are going to shorten, but this can actually be prevented by the telomeres reverse transcriptase. Now, excessive telomere shortening can actually trigger apoptosis or cell senescence. In the neurons, their telomeres don't shorten because they are postmitotic. However, the newly formed neurons are vulnerable to apoptosis that is going to be caused by the telomere damage. As a result, the hippocampal neurogenesis is going to be reduced, and there's going to be impairment of the hippocampus-dependent spatial learning and memory. And finally, we have the dysregulated energy metabolism. There's going to be an increase in the circulating glucose due to the inability of the cells to increase the glucose transport in response to insulin, so leading to insulin resistance. A risk factor for Alzheimer's disease was shown to be peripheral insulin resistance, which can cause poor cognitive function. But what can we actually do in order to slow down this process? First of all, there are some gene variants that could be targeted, that could be associated with the development of dementia. We have the ApoE that is normally going to break down the beta amyloid that is associated with Alzheimer's disease, with the epsilon-4 allele encoding for a less effective ApoE. So the use of anti-ApoE epsilon-4 antibodies in individuals with those alleles can help to reduce the amyloid deposition and restore the cerebral vessels function. Another way is to target the DNA damage. This can be achieved through the inhibition of the DNA damage response proteins, like proteins like ataxia, telangiectasia mutated, RD3 related, and the DNA-dependent protein kinase. In addition, another approach is regulating the deacetylase enzymes. One example is activating the histone deacetylase 1 with exophone that was actually shown to have lowered the DNA damage, so improving cognitive function. Regular exercise and managing the sleep disorders can also improve the DNA repair, and protective factors against DNA damage include the avoiding excessive alcohol consumption, smoking, and UV exposure. Also, we have maintaining the telomere length can be achieved with therapeutic agents that are going to target the telomerase. There are compounds that can regulate the telomere function, include TA65, which can activate telomerase. The regulation of the mitochondrial dysfunction and oxidative stress can help to prevent aging, brain aging, and dementia. It was shown that dietary restrictions and exercise has improved the function of the mitochondria and decreased the oxidative stress. One example, we have the hesperidine that was shown to enhance the antioxidant defenses, thus reducing the mitochondrial dysfunction, the formation of the alpha-beta plugs. Finally, an unhealthy lifestyle was linked to most dementia cases. High alcohol consumption can help to speed up the cognitive decline and brain aging. Dietary restrictions, increased sleep, and sleep therapy was shown to slow down the brain aging and neurodegeneration. Exercising can help to regulate the histone modification and stabilize the mitochondria, reduce the neuroinflammation, and maintain the blood-brain barrier. So as a quick recap, there was shown to be many mechanisms that are associated with brain aging. The gross changes include cerebral atrophy, the sulci widening, and cerebrovascular changes. Those cellular molecular changes mainly occur in the nucleus, in the mitochondria, the lysosome, the calcium homeostasis, and so more as we discussed before. So as we age, the DNA expression is going to change, and there will be shortening of the telomere length. Early prevention and managing the modifiable risk factors for brain aging are of utmost importance. Addressing them can help to slow down the cellular and molecular changes which are associated with brain aging. It is important to understand and limit those risk factors in order to promote a better quality of life and healthier brains. Thank you for your attention. Do you have any questions you would like to ask? If not, thank you.
Thank you very much, Rodothea. Now we will move on with the third presentation, and we have Elena Zouganelli with cerebral malaria, a silent threat to brain health.
Hello everyone, and thank you all for being here today. My name is Elena Zouganelli, and I am a second-year medical student. And today I'm going to show you my work on cerebral malaria, a silent threat to the brain's health. Now here is our abstract. This is the things we're talking about today. Let me start with a question. What do you think is more dangerous for the brain, trauma or a mosquito bite? Most people would probably respond with a trauma, but today I'm going to show you why a mosquito bite is just as deadly with head trauma. Starting off, CM, or cerebral malaria, is caused by Plasmodium falciparum. If you're not aware of Plasmodium falciparum, it is a unicellular protozoan parasite in humans that causes the most severe malaria. It doesn't just cause fever like regular malaria. It enters your body, invades your brain, clogs your blood vessels, leading to coma and brain injury and sometimes death. Ask yourselves, how many kids under 5 can recover from coma without long-term effects? Not many. That's why this matters. Moving on to the epidemiology. Here, where it hits the hardest, most of cases are in sub-Saharan Africa and some in Asia, mostly in children under 5. In the US, in Europe, it's rare, mostly seen in travelers. Can anyone guess why children and pregnant women are more at risk? Okay, let me answer the question. It's because they have a weakened immune system. Moving on, we have bar charts here. The first bar chart confirms what the map suggests is. Sub-Saharan Africa has by far the highest mortality. Why? Because children there are exposed repeatedly, often without treatment. Meanwhile, mortality in Southeast Asia and Latin America is much lower, as you can see in the bar chart. Moving on, the second graph breaks it down by age. Under 5 years old are at highest risks because, as I mentioned before, their immune systems aren't strong enough. And adults are less commonly affected, but cases in travelers are on the rise, as we've seen on the map too. Then the third bar chart really brings it home. Among survivors with cerebral malaria, many have long-term brain problems, such as memory loss, learning difficulties, and behavioral changes. Now, moving on to the pathophysiology. Let's look at how CM affects the brain. The parasite, the Plasmodium falciparum parasite, enters your body, reaches your brain, clogs your bloodstream, disrupts the blood-brain barrier, and this causes swelling, inflammation, and even hemorrhage. As you can see here, this is what I talked about. The result is swelling, inflammation, and even hemorrhage. The results, coma, seizures, abnormal posturing, and often death or lifelong neurological issues. Moving on to symptoms. Now, imagine a 4-year-old with fever, seizures, and confusion who slips into a coma. And let me say, that's a classic cerebral malaria case. Even if they survive, many are left with memory loss, learning difficulties, or behavioral problems. So here I have a chart. This chart here shows the types of cognitive issues survivors face, and these can last a lifetime. You can take a look at them. Here we have the general and systemic symptoms. But here in this presentation, we're focusing on the neurological symptoms. Moving on to the diagnosis. Of course, diagnosis starts with clinical suspicion, especially with someone with travel history. We confirm cerebral malaria with a blood smear or rapid diagnostic test, and imaging like CT or MRI can show severe brain swelling. Moving on to treatment and prevention. Treatment is a race against time. Intravenous artesunate is the treatment of choice. Supportive care, like controlling seizures, fluids, and oxygen, is clinical. But let me say that treatment is not always enough. Prevention is much, much more important. Prevention is simple yet powerful. 3 things, we can all do them. Mosquito nets, insect repellents, preventative medicine. It is really important to use anti-malarial prophylaxis, and it's really, really simple. Also, vaccines like RTS prevent cerebral malaria, but they are not the first line treatment like IV artesunate. Now, we have a case study here. Let me tell you a true story. We have a 48-year-old man that went to South Africa with no prophylaxis. Big, big mistake. He returned with fever and confusion, and soon was in a coma. As you can see on the screen, he had 24% parasitemia, which means 1 in 4 red blood cells were infected from the parasite Plasmodium falciparum. The MRI showed brain hemorrhages and swelling, as you can see on the screen or the image I have there. Fortunately, with rapid treatment, he made a full recovery, which is really rare. So, what is the lesson here? Malaria doesn't care where you're from. Now, to conclude, CM is a brain disease disguised as a tropical infection. It has high mortality, and survivors often suffer lifelong brain damage. So, remember, early diagnosis, prompt treatment, and strong prevention strategies like bed nets and vaccine save lives. That's it. Thank you so much for your attention, and if you have any questions, let me answer them for you. Thank you. Do you have any questions? No? Okay, thank you.
Thank you very much, Elena. Our next speaker is Christos Rafael Karathanasis with a presentation titled Surgical Procedures for Kidney Stone Removal.
Hello everyone. Today we'll be speaking about the surgical interventions for kidney stone removal. Kidney stones, or as nephrolithiasis, are mineral deposits in the renal calyces and pelvis that are found free or attached to the renal papilla. Kidney stones occur when there is an excess of crystal-forming substances that can be dissolved in urine. Examples of these substances are calcium oxalate and uric acid. Most of the stones, the majority of them, nephrolithiasis is a common disease, and they affect approximately 12% of males and 6% of females worldwide. The majority of stones, around 75% of them, are composed of calcium salts. So when a stone becomes obstructed, either in the kidney or the urinary tract, the patient will feel a severe renal pain starting from the upper lateral back that radiates anteriorly and inferiorly towards the groin. It is worth mentioning that many women rate the pain as worse than childbirth. According to studies, kidney stones usually do not require any intervention as they are naturally excreted through the urinary system. Only 10 to 20% of nephrolithiasis cases require surgical interventions. And these are the main surgical interventions. The first one is ureteroscopy, then we have percutaneous nephrolithotomy, and then extracorporeal shockwave lithotripsy. Ureteroscopy is a minimally invasive procedure where a scope is passed through the urethra to the ureter. We have two ureteroscopes, the rigid that is used for the lower ureter and the flexible for upper ureter and kidney. Small stones are extracted using a basket, larger stones are fragmented with a laser, and then a temporary stent is placed postoperatively. And in the middle we can see the rigid ureteroscope, and then this is the flexible ureteroscope. This is a case of a ureteral stone that was obstructed in the ureter. At the image A we can see the stone being obstructed. At the image C and D, a laser is used to pulverize the stone, and in the image E, the stone fragments are removed through a basket. So the pros and cons. The advantages of ureteroscopy are its high success rate, the direct visualization, and the fact that it is minimally invasive. The disadvantages include discomfort from stent, ureteral wall injury, and residual fragments. The second procedure is called percutaneous nephrolithotomy. This is mainly used for large stones above 2 centimeters and for complex stones. In this procedure, a small incision is made in the back of the patient. Then an implant sheath is placed through the incision. The implant sheath is the blue tube that you can see in the image right here. And then a nephroscope is inserted into the kidney through the sheath. Stones are fragmented mechanically or with a laser. Then a nephrostomy tube is placed postoperatively. The advantages are the high success rate and that it is effective for large stones. The disadvantages are that it is more invasive and there is a risk of organ damage and infection. The last procedure is the extracorporeal shockwave lithotripsy. This is the only non-invasive procedure, and up to 3,000 high-energy shockwaves are emitted to fragment stones. It is an ideal procedure for stones that are less than 10 millimeters. This is performed either with sedation or anesthesia and it fragments stones into passable pieces. This is the extracorporeal shockwave lithotripsy that you can see in the image above. While extracorporeal shockwave lithotripsy avoids surgical incisions and has a short recovery period, it has many disadvantages. The infection risk is up to 10%. There is a risk of incomplete fragmentation and Steinstrasse. Steinstrasse is the accumulation of ureteric stone fragments causing ureteric blockage. The treatment for Steinstrasse is either conservative or surgical. Conservative meaning we hide the patient and we administer pain medication. If this doesn't work, then we proceed with ureteroscopy. And the last disadvantage is that it can cause perinephric hematoma. We need to have in mind that kidney stones are frequent health issue and can cause severe pain to the patient. Fortunately, most kidney stones pass naturally. Even though all three methods can successfully treat kidney stones, each has distinct indication, advantages and potential complications to the patient's health. Thank you very much. Do you have any questions?
Thank you very much, Christos. Now we will move on with 3D bioprinting in airway reconstructive surgery, which will be presented by Elisa Hadzikakou.
So hello everyone, I'm going to be presenting the topic of the revolutionizing airway reconstructive surgery and the promise of 3D bioprinting. So we'll start off with the clinical problem. So the trachea is vital for breathing, but it can become damaged or narrowed due to thyroid cancer, congenital anomalies, or just trauma. And traditional treatments often fail to fully restore the trachea to what it was. So that's where 3D bioprinting steps in, and it offers a patient-specific, promising new approach that could dramatically improve outcomes for those with severe tracheal defects. So the actual bioprinting process. So the bioprinting process begins with a CT scan of the patient's trachea, and this gives us detailed anatomical data, which is then converted to a digital 3D model. This model becomes the blueprint of the printer, allowing us to create a personalized structure that precisely fits the patient. So next we use a special form of ink called a bioink, which is made from hydrogel mixed with living cells. And these cells can include things like chondrocytes, if we want to make cartilage, or epithelial cells, which line the airway. And oftentimes these cells are taken directly from the patient to reduce risk of rejection. Then the bioprint is printed layer by layer onto a biodegradable scaffold, which is usually made from materials such as polycaprolactone, which we'll talk about soon. The printing method is often like extrusion based, which means the bioink is pushed out like toothpaste through a nozzle, but with high precision. And once the shape is printed, we're stabilizing it using a process called cross-linking, and we can use this either with UV light or ionic solutions. This step helps the structure hold its shape and prepares it for cell growth. Next, when the construct is placed in a cell culture, like an incubator, to allow for cell growth, maturation, and then allowing it to begin forming tissue. And finally, once it's fully prepared and biocompatible, the engineered trachea is surgically implanted within the patient. And this result is a custom-built airway that can integrate within the body and potentially restore breathing function far better than any traditional graft could. So onto the scaffold materials. Scaffolds are the backbone of 3D bioprinting tracheal implants because they provide structure that supports the cells and helps guide tissue regeneration. But not just any material will work. An ideal scaffold should be biodegradable so it breaks down safely once the new tissue is strong enough. It should also be biocompatible so it doesn't create an immune response within the patient. And it also has to have mechanical stability so it can hold the airway open under the constant pressure of breathing. And lastly, it must support tissue integration, encouraging the body's own cells to grow into and around it. So here I've listed the 3 most common materials used, starting with polycaprolactone or PCL, which is particularly favored because its mechanically strength resembles native tracheal cartilage and it degrades slowly, which is ideal for long-term therapy as you would want with a trachea. Also, PCL's low porosity helps keep the structure stable, and its smooth generation makes it predictable in a clinical setting. Next, we have PGA and PLGA, which are more porous, so they break down faster, but they don't offer enough strength for long-term tracheal use. And lastly, we have polylactic acid, or PLA, which is FDA approved, but again, may not provide the strength needed for certain reconstructions. For cell and hydrogel source, incorporating cells such as chondrocytes or ciliated epithelia in case of artificial trachea production is often done via a hydrogel. So natural materials such as collagen, hyaluronic acid, and extracellular matrix components provide excellent biocompatibility, but they often lack mechanical strength, so they are typically combined with synthetic materials for optimal results. So these are the most common design options for the tracheas. We have circumferential repairs, we have airway stents, we have mini plates, and then we also have circumferential reconstructions. And here I have some case studies to show you. So one promising example comes from a clinical study by Lishka and colleagues, and that's the corresponding image there. They treated 6 patients who developed airway narrowing after lung transplantation by endoscopically implanting biodegradable stents made of polydiaxanone, or PDS. So these stents were placed endoscopically, and they initially relieved the airway obstruction for all 6 patients. And importantly, there are no cases of bleeding or no cases of the stents moving, which we often get with traditional methods. However, about 2/3 of the patients eventually needed re-stenting after a median of 5 months, showing that while effective, durability is still an issue we need to address. And also, one patient did unfortunately die a year later of a pulmonary embolism, but the other 5 remained intervention-free for up to 44 months when the study ended. So I think this is an impressive long-term result, especially for such a complex problem. Another approach is non-circumferential reconstruction, where only part of the trachea is repaired rather than the whole circumference of it. So I have two studies here, and the researchers use a 3D printed PCL patch to rebuild the airway stents, but the results were mixed. So in the first study, which the image is there, it was a sheep study by Townsend and colleagues, and results were mixed. So 4 out of the 5 sheep actually had to be euthanized within 10 weeks because of respiratory distress. This suggests that we have problems with integration or mechanical performance. But in contrast, in the second study by Rahmani and colleagues, they reconstructed 4 centimeter long tracheal defects in pigs, and 5 out of the 7 pigs survived beyond the 3 months that the study took place and showed strong tissue healing, mucosal coverage, and also blood vessel formation. These animal studies tell us that success can vary a lot depending on species and surgical technique, and they emphasize how important it is to optimize not just the material, but also the design and the biological environment the implant is actually in. So the human trial. In August of 2023, it marked the first ever implantation of a custom 3D bioprinted trachea in a human. Okay, the surgery was performed in South Korea on a woman in her 50s who had lost part of her trachea because of a thyroid cancer surgery. So the trachea was printed using a PCL scaffold for strength, which was then combined with a bioink, which is derived from nasal stem cells and cartilage cells sourced from other patients. And at the 6-month follow-up, the results were incredibly promising. So she had, the graft had fully healed, she had new blood vessels forming, and the patient was reportedly doing well. So this is a major milestone because it proves the concept that a custom bioengineered trachea can work in a real-world clinical setting and in humans. It's a huge step towards the future of personalized airway reconstruction. However, just a note, no further details about the patient's condition have been disclosed in English or Korean media sources since then, but this could be due to a lack of information because of patient privacy considerations or just the absence of new developments deemed significant for public release. So challenges and ethical considerations. Despite these successes, challenges remain. So technically, we need better materials, we need improved vascularization, and we also definitely need long-term data on the implant's durability. And for ethical concerns, we need issues to address is patient concern, accessibility, and then also stem cell sourcing. They're important issues to address before this can become a standard treatment practice. In conclusion, 3D bioprinting represents a groundbreaking advancement for trachea reconstruction, and it holds the promise of tailored, effective treatments for patients that have really few other options. And moving forward, innovation in materials and addressing ethical challenges will be critical for this technology's success. These are my resources. Thank you for listening.
Thank you very much, Alisa. Now we are moving on to a 10-minute break, and we will come back at 10:40 to continue with the rest of the presentations. Thank you. Hello again, everyone. We are beginning now with our second session of presentations. So now I would like to call Harilos Panoudis to present his presentation with title Red Light Therapy and its uses in dermatology. Thank you.
Okay, hello everyone. So we're going to talk about red light therapy, which is a novel, non-invasive method for dermatology. Here's a quick synopsis of what I'll be talking about. So what is red light therapy? Also known as low-level laser therapy or near-infrared therapy. It is an up-and-coming field of dermatology that is completely non-invasive. It has a few studies and it seems to have promising results. That's great for us because in the field of dermatology, even though we've made big leaps, most interventions still are invasive and are not optimal. So a quick lesson on skin aging, which is a normal part of our aging process. It mainly has to do with the breakdown of elastin and collagen fibers. Of course, when we're young, there is the ability to repair all of this, but as we get older, this ability is reduced, and other mechanisms like telomere shortening, increase of cell senescence, and the abundance of ROS affect this, and also our genes can accelerate or decelerate this process. So how does the red light therapy itself help us? Well, the theory behind it is that it can activate our mitochondria, specifically the cytochrome C oxidase, which in turn increases our overall ATP production output. And this then improves further on the signaling and the healing of the skin cells. There is also strong evidence that this has an overall strong anti-inflammatory effect. It can promote hair growth in the case of androgenic alopecia, and it can change some gene expressions. All of this is dose dependent, so it needs to be monitored by a medical professional. Overall, in the research that we've had so far, it is relatively promising with few side effects, and most of the patients were satisfied. However, what we use in studies, meaning the irradiance, which is the power delivered by the laser, the power density and total energy, even sometimes the wavelength and the frequency of the device used by the participants is completely different from one study to the other, and this provides some challenges for us later on because we don't know in which patient to give which device and for how long. Comparing the different types of LED devices, red light therapy, red LEDs show a slight advantage in wrinkle reduction, but they also have a higher incidence of side effects. These side effects usually have to do with erythematose of the skin, some itching, and in the cases where a protective shield was not correctly placed on the eyes of the patient, there were some mild damage of the retina. Overall, most studies, however, can agree that the optimal treatment frequency is for 2 to 3 sessions per week, and we know that the patients need to use these devices for at least 6 or so months to see visible reductions of the wrinkles. As I've said before, there is some limitations with the current research. Most studies feature a very small sample size, around 30 or so participants, sometimes less. There were clear demographic biases. For example, most of the studies were on women of Asian descent at an older age, and all of these reduce the generalizability of the results we see to a bigger population. And because of the lack of standardized effects, we cannot be sure which patient requires which device, and so on and so forth. But in conclusion, red light therapy is a promising intervention for the future of skin anti-aging and skin rejuvenation, and even more. However, without further guidelines and more comprehensive guidelines, we still cannot recommend it on a mass appeal for more people. And yeah, thank you very much. Any questions?
Thank you, Harile. Now we will move on. Now we will move on with Rosa Tsoukalas and her presentation with title Saturated Fat Intake and Cardiovascular Disease.
Hello everyone, thank you for coming. My name is Rosa Tsoukalas. I'm a biomedical scientist and a second-year medical student. And today I'll be talking to you about saturated fat intake and cardiovascular disease and giving a new perspective to the equation. Here's what I'm going to talk about today. First, I'll provide an abstract about the subject, then go into what are saturated fats, the historical context behind this perception, the diet-hard hypothesis compared to recent evidence, and why considering food groups in the context of nutrient distribution is essential, and then some concluding remarks and future directions for guidelines. I would like to start by making a question to the crowd. Consider this statement: eating saturated fats significantly increases your risk of cardiovascular disease. Which ones of you here think this is true? You can raise your hands. Okay. And which ones of you here think this is false? You can raise your hands. Okay. Let's see if the result changes by the end of this presentation. So the concept of limiting saturated fat intake has been around since the 1950s. However, evidence from recent studies shows that saturated fat intake is not associated with mortality or cardiovascular events. Yet the dietary guidelines still persist in their recommendation. This presentation aims to shed light on the recent evidence regarding saturated fat intake and urge policymakers to update such guidelines. So let's talk about what are saturated fats. Saturated fats are a type of fat that are composed mainly of saturated fatty acids. And as you can see in the image, the characteristic of saturated fatty acids is that they do not have a double carbon-to-carbon bond. This is in contrast to unsaturated that do have a double bond. They're solid at room temperature and can mostly be found in foods such as red meat, dairy, chocolate, and some other foods. So let's provide a historical context of how this perception came to be. In the late 1950s, Dr. Ansel Keys proposed the diet-hard hypothesis. He was the first to propose that a diet high in saturated fat increases the risk of coronary heart disease. And he led the study, the 7-country study, where he observed the consumption of saturated fat and the incidence of coronary heart disease. So this study has shaped our perception about saturated fats until today. However, many scientists have questioned the validity of this study because it has multiple limitations. More specifically, population-based studies, which is the case in this study, are less accurate in establishing cause and effect. They also don't capture individual-level studies and are often affected by bias. Also, the selection of countries was non-randomized, meaning that he could have cherry-picked the countries he wanted in order to prove his hypothesis. And finally, the methods of dietary habit evaluation are thought to be non-standardized because he included Crete during the period of Lent. This means that there was no consumption of animal products, so the result could have been affected by this. Before I go into looking at the recent evidence, I would like to provide a quote by Dr. Asim Malhotra, a cardiologist, saying that the diet high hypothesis has been repeatedly shown to be wrong, yet it persists. It's time to abandon outdated dietary guidelines. And let's see why. So, a systematic review published at the British Medical Journal analyzed observational studies reporting associations of saturated fat with cardiovascular events. They found that saturated fats are not associated with all-cause mortality, cardiovascular disease, coronary heart disease, ischemic stroke, or type 2 diabetes. And this is also depicted in the graph below. There are some discrepancies in the statistical significance, but the overall conclusion was that saturated fats do not cause cardiovascular disease. Moving on, a state-of-the-art review published at the Journal of the American College of Cardiology looked at cohort studies where saturated fat intake was replaced with carbohydrate consumption. And they actually found that there was no decreased coronary heart disease risk. So as we can see from these two studies, consuming saturated fat does not increase your risk of cardiovascular disease, and reducing the consumption of saturated fat does not confer a protection against cardiovascular disease. So I would like to highlight why considering food groups in the context of nutrient distribution is essential. Dairy and red meat are often avoided due to their high content in saturated fat, although they are both foods rich in nutrients. More specifically, red meat includes macronutrients such as fats and all essential amino acids, and it also includes micronutrients which are essential for the normal functioning of the human body. More specifically, it has vitamin D, magnesium, selenium, potassium, and more. Also, it's worth mentioning that nutrients within red meat are bioavailable, and this means they can be utilized by the body, in contrast to plant-based sources, which are less bioavailable. The alternative recommendation for replacing saturated fatty acids is usually the consumption of carbohydrate. However, this is interesting because refined carbohydrate lacks nutrients and is actually associated with an increased risk for metabolic syndrome development. And as you can see, the criteria for metabolic syndrome, 2 out of the 5 are risk factors for the development of cardiovascular disease, namely low levels of HDL cholesterol and hypertriglyceridemia. The PURE study looked at the dietary intake of more than 100,000 individuals, and they recorded the total mortality and cardiovascular events upon follow-up. They actually found that higher carbohydrate intake was associated with increased mortality risk, and that higher consumption of saturated fat was associated with a lower risk of stroke. Moving on to some further evidence, a systematic review and meta-analysis published in the Clinical Nutrition Journal recently found that increased consumption of dietary carbohydrate is associated with an increased risk of cardiovascular disease, stroke, and all-cause mortality. Moreover, the prospective study published in the American Journal of Clinical Nutrition looked at a group of more than 70,000 women aged 38 to 63 and showed that refined carbohydrate consumption increased the risk of coronary heart disease. So to conclude, we can see that the diet high hypothesis, which was shaped in the 1950s and has multiple limitations, has influenced today's perception and guidelines regarding saturated fats. This is considering results from recent studies. We can see that there's no evidence that saturated fats pose a health risk. In the contrary, there are observed health effects of saturated fatty acids, such as proposed stroke protection and the provision of essential micronutrients. The alternative dietary recommendations of increased carbohydrates lead to the intake of processed foods and increase the risk of mortality. I would like to highlight that foods high in saturated fats have essential nutrients for the normal functioning of the human body, and it is imperative to include them in our diet. To close off, dietary guidelines must be updated based on the emerging evidence that saturated fat consumption does not introduce a health risk, but rather a health benefit for the population. And finally, I would like to pose this statement again and see the reaction of the audience. So which ones of you think still that eating saturated fats significantly increases your risk of cardiovascular disease? You can raise your hands. Okay, it's interesting to see that the perception has changed. And which ones of you here think that this is false? Perfect. And finally, I would like to close off with a quote from William Osler, the father of modern medicine. And he says that the philosophies of one age have become the absurdities of the next, and the foolishness of yesterday has become the wisdom of tomorrow. Thank you so much for your attention, and these are my references. Are there any questions? No? Okay, thank you.
Thank you very much, Rosa. Now we will move on with that Skalali presentation with the title Genetic Factors Contributing to the Development of Inguinal Hernias.
Good morning, everyone. So my name is Dadis Kalali from the University of Cyprus, and today I will be talking about the genetic factors contributing to the development of inguinal hernias. And this is actually from a paper that I've published in the European Journal of Clinical and Experimental Medicine last year. So the results have been peer-reviewed, confirmed, and published in a journal, a pan-European journal. Okay, so introduction. Inguinal hernias. How many of you here know what's an inguinal hernia? Okay, so I guess like first year and second year students might face some difficulty understanding what an inguinal hernia is. So I will be explaining what that is. No worries. So inguinal hernias are basically a topic of general surgery. Oh, come on now. General surgery, genetics. Are you joking? No. Molecular medicine is actually becoming the center of all specialties now. And that's where we're moving towards. The future is molecular medicine. You're going to be seeing molecular medicine in every subject, even in general surgery. Okay? So don't be shocked by the fact that I'm combining general surgery with molecular medicine here. An inguinal hernia, basically, for those who are first-year students, I will be explaining what it is. It's basically a surgical issue. It's common. You will see it a lot in surgical clinics. It's basically some organs of the abdomen. Usually we're talking about intestines, okay? And these intestines, they herniate. In other words, they kind of go through the abdominal wall. So they break through the abdominal wall, and you see that the organ creates an inguinal sac, okay? Which is like a small bag called the inguinal sac. Okay, so here in inguinal hernias, it's more common in males. So we have a prevalence of around 9 to 10% in males, biological males, and around 1% in biological females. The types are two types: direct, which means actually through the abdominal wall, or indirect, which is through the inguinal ring. So the inguinal ring is basically a canal, okay? It's a canal that contains the spermatic cord, okay, and some nerves. And this canal is like this anatomically. So if an intestine goes through the canal directly, like this, okay, it's called an indirect. So that's a bit confusing. You have to take it in mind when you're talking about indirect. It means it goes through the canal directly. But when it goes directly through the abdominal wall, then it is considered, okay, a direct hernia. Clear until the moment what we're talking about? Great. So the only possible treatment is surgery, as I said. And now we are gaining attention to the fact that genetics play a significant role here, okay? Let's go to see what study this person standing here has conducted. Okay, so what we conducted in this, not we, okay, I did on my own, this review, it's a narrative review that I conducted. The aim was to see what role genes and genetics and general molecular medicine plays in inguinal hernias. So I searched the databases, the electronic databases, PubMed, Scopus, Embase, and Google Scholar, that you can see here. Okay, I used the following keywords, very generalized keywords, no specific inclusion-exclusion criteria. Okay, genetics, genome-wide association studies, GWAS, for those of you who are not familiar with this, I will explain later what it is. Inguinal and hernias. Simple, short, and no specific criteria. So let's go to see what we found. I found a lot of studies, okay, and I made a synthesis of the studies to be able to describe, because it's the first time that it has been described in literature by me. So I'm gonna briefly present here what results I found. So basically, we have two different mechanisms. We've got weak abdominal wall in direct inguinal hernias and in indirect inguinal hernias. Okay, I remind you, indirect is the ones that go through the canal. Okay, we've usually got fetal development defects. So you see it's more common. You see indirect hernias more common in children, but direct hernias are much more common in adults, and usually in men above the age of 60. Okay, so we have these two main categories of mechanisms, both of which I will explain. So when you're talking about weak abdominal wall, then the extracellular matrix is crucial, because that's basically what forms the basic structure of the abdominal wall. It's muscles, and between the muscle cells, we have extracellular matrix. So decreased type 1 collagen, increased type 3 collagen, both result in weaker structure. Okay? And there are actually some great evidence that if you divide, let's say, the amount of type 1 collagen, let's say, we're not talking about numbers, not mathematics, I'm just trying to give you an image. If you divide type 1 collagen by type 3 collagen, okay, so we're talking in gene-wise quantities, which I'm not going to take you into, because here we're not talking about genetic students, we are talking to medical students, so I'm not going to explain that a lot. But let's say if we call it the ratio type 1 over type 3 collagen, if that ratio is low, then we have weak abdominal muscles. Then we've got elastin fibers, which are reduced in hernia patients. Okay, logically, elastin, what it does, stretch muscles, make strong muscles in the abdominal wall. So if you have reduced elastin, like you have also reduced elastin, where? In aging. That's why in aging, we have muscles which get weakened in our face, in our hands. And that's where the main problems of aging come with. It's a part, anyway, there are a lot, I don't want to get into the topic of aging, but we see that the elastin also plays a role there. But if you have a genetic defect that causes reduced elastin fibers, then okay, you are at risk of hernias. Next, you have fibulin 3, which is downregulated. Fibulin 3 is not related to direct inguinal hernias. It's related to indirect hernias. So we're talking about hernias usually in children because it's a growth factor. And tenascin X, okay, if you have deficiency in tenascin X, so I don't want to get you explaining what tenascin X is because it's going to turn into a genetics lecture and that's not what I want. So I want you to take your phones, take ChatGPT and make a search. What is tenascin X? It's a growth factor, okay? So if you have a deficiency, you have problems with the production of tenascin X, then you have the result of indirect hernias. Now let's go to growth and differentiation factors. So growth and differentiation factors, again, they go back to indirect hernia. So for direct, we've got elastin until the moment, okay? And we've got collagen type 1, collagen type 3, and the ratio of the collagens. Here, we're again talking, when you're talking about growth and differentiation factor, growth. Okay, so my mind is going to think of more children, right? Because that's where growth deficiencies play a role. So when you have growth deficiencies, again, we're talking about indirect hernias. It's problems that even during gestation usually they occur. Okay, so during pregnancy at 8 to 10 weeks, and defective signaling in androgens, because as I told you, it's more common in males, it causes problems with the inguinal canal. So the inguinal canal is wider, and a wider inguinal canal is a defect which causes herniation and increases herniation risk, okay? So here, it's a figure that I created, and you see that everything is summarized up, everything I said, so I'm not gonna stick to this slide. Just take a look at it, you see what it is. Here is the inguinal canal, so if the hernia comes like this, through the canal is an indirect hernia, usually children, or if you have weak muscles here, and you have the hernia coming like this, okay, then we have a direct inguinal hernia, and you see that anything that causes wide canals or entire incomplete canal closure can make indirect hernias, and anything that causes weak muscles, direct hernias. Okay, until the moment? Great. So if you have any questions, jot them down, because at the end of the presentation, I want questions. Okay, I want engagement here. So, key genes. Going to our main topic, genes. Yeah, that's the word, genes. Which genes play a role here? Collagen. Okay, it's clear. Collagen is going to play a role. Then we've got elastin. Elastin, yeah, I told you, it's going to play a role. Now we come to my favorite type of enzymes, which I've done a lot of studies on them, MMPs, matrix metalloproteinases. What are these? They are basically enzymes, to tell you in simple words, that they eat the extracellular matrix. They destroy the extracellular matrix, different components, collagen, elastin, fibrin, different components of the extracellular matrix. They are called MMPs, okay? Then we've got the Wilms tumor protein gene, which codes for a transcription factor responsible for the development of urogenital disease. Does anyone know what the Wilms tumor is? From which organ you have a Wilms tumor? Hands? Wilms tumor? Anyone? Yes, it's a kidney cancer. So it's basically a kidney cancer in kids, okay? To be simple. Wilms tumor is a kidney cancer in kids. Those who are interested in pathology like me, they're gonna know the subtypes. It's not necessary, okay? But it's good to know pathology always. So next we've got the EGF-containing fibulin-like extracellular matrix protein gene 1. Okay, long story. What it is, it's basically a protein that regulates the composition. So it says, okay, you're gonna make this much elastin, this much fibrin, this much, okay, collagen. It's the coordinator here, okay? Then we've got the T-box transcription factor genes. It's a family of proteins for embryonic development. So when talking about embryos, okay, what type of hernias? Direct or indirect? Not direct, indirect, okay? So indirect, there's usually in children. Indirect, infants. I want you to keep this, it's very important. So, next, we've got the lysyl oxidase-like 1 gene. It's an enzyme that helps biosynthesis of elastin. Okay, we are back to our old friends, elastin collagen, okay? So it's an enzyme that helps the biosynthesis of elastin. And then we've got sirtuin genes. There are several proteins, okay? And they help muscle formation. So they help having good abdominal muscles. So a deficiency there leads to direct inguinal hernias. Here you can see some polymorphisms. I'm just going to explain how we read these polymorphisms because it's usually people see it and they run away. Polymorphisms, they run away. No, it's not so scary. Things are simple, how we show polymorphisms. So you have got different polymorphisms. Let's say here it's a polymorphism in collagen 1A, okay? Col 1A1, which is the first chain of collagen type 1. It makes quadruple risk increased for direct inguinal herniation. Then we've got the elastin. Okay, so how we read this is, let's say, this position of the gene. You've got substitution of the A nucleoside, adenosine, by guanine. Okay, clear? Great. Then we've got Wilms tumor 1 protein, FMP1, usually affects the females. And then we've got transcription box X2 and TPX3, which is in indirect hernias. It's a growth factor. Okay. Additional insights are LOX1 downregulation. Don't want to get into genes, as I told you. ChatGPT is there, it's going to help you. Okay? So you're going to take a look what is LOX1 gene. These are basically genes, all of them that help closure of the canal. So you're going to have wide canals, okay, when you have deficiency in these genes. Here is a table. You can read it in my paper, so I'm not going to go over the table. Now, how many genome-wide association studies have been conducted? Thankfully, it's 5. It's good. It's a good number. We want more to be conducted, but it's good. It gives enough evidence when you have 5 genome-wide association studies. In USA, in Japan, and in the UK. So you've got sample sizes of 700K controls, usually. They found 4 to 69 genetic loci, in other words, genetic positions identified, okay? You've got, again, the genes that we talked about, elastin, Wilms tumor, okay? Repeating agenda. I'm not gonna repeat myself again and again. And some of them are sex-specific, which means like this mutation is related to herniation in females, biological females, or in biological males, okay? And here is a list of all the studies. The only thing is that only one of the studies is multi-ethnic. And that's important because we need to have multi-ethnic studies when we're talking about genes. The other ones are only in Caucasian and Asian populations. One is in Asian populations in Japan, and the other 3 are only Caucasian patients. So there we have a little bit of bias, okay? Our conclusions are future directions. They are multifactorial, so inguinal hernias, it's not surgery only, okay? I don't want to hear a future surgeon saying it's only our matter, okay? It's also a matter of the molecular medicine specialist. It's also a matter of the geneticist. It's also a matter of the pathologist, okay? We've got genetic screening, which can help us find patients who are at risk. So we're going to tell them, okay, you have the gene. You have to be more careful. Make abdominal muscle wall exercises, which help. So they're going to take preventive measures if they know, okay, they're going to make inguinal hernias. We have some gaps still. We need to perform more studies, hopefully, and hopefully I will do some studies in the future. I'm looking forward to do some studies here on the MMPs. As I told you, they're my favorite category of enzymes. And we need more global studies to take into consideration other ethnic populations, okay? Because most of them, as I told you, were in Caucasian populations. Thank you. Are there any questions? I'm looking for hands up here. No questions? Clear? Great. Thank you so much for your attention, guys.
Thank you so much. And now we're going to go to the next one. We're going to welcome Katerina Bogdanou with the presentation title Chios Mastica Effects on Euthypedes. So let's give a warm welcome.
Good morning. My name is Katerina Bogdanou. I am a first-year medical student at European University of Cyprus. I would like to start my presentation by asking the following question. Can something as simple as a tree resin hold the key to managing one of the world's most pressing health issues? It actually can. Allow me to introduce to you an ancient natural remedy, chiosmastic resin, and explore together how it can help transform the way we manage diabetes. Diabetes is a frequent disease nowadays. As we all know, it consists of two types, type 1 and type 2 diabetes. Type 2 in particular has become a global epidemic with serious implications, such as heart disease, kidney failure, vision problems, and the list goes on. What about conventional treatments? They work, they do. But they often come with a price. So what's that? Side effects, high costs of medication, and reduced effectiveness over time. What if nature could lend us a helping hand? This is where chiosmastic comes in. So now let's talk about the limitations in current diabetes treatments. I want you to picture this. You're a patient with diabetes, and now you don't have to deal with just that, but you also have to deal with nausea, low blood sugar, or weight gain due to the medication that was prescribed to you. Or you have to pay enormous amounts of money every single month for medication that slowly stops working. It's frustrating, right? So, the effectiveness of some drugs diminishes over time, especially as pancreatic beta cells function declines. Now we have both patients and medical practitioners starting to ask themselves, is there a safer, more sustainable way to deal with diabetes? There actually is. Let me take you to the island of Chios, Greece. For over 2,500 years, people have harvested a resin from the Pistacia lentiscus tree, known as chiosmastic. No, this isn't just a folk remedy. It's packed with over 120 natural compounds, such as flavonoids, essential oils, and phenolic acids, all working like nature's little chemists. Phenolic acids and flavonoids are natural compounds that have antioxidant properties, and they support brain function, heart health, immune support, and they reduce the risk of chronic diseases. And today, scientists rediscover what traditional healers already knew. No, mastic isn't just for freshening your breath. Studies have shown that it reduces inflammation and it acts as an antioxidant. It fights bacteria, it lowers cholesterol, and yes, it may even help balance blood sugar levels. We're talking about a resin that does more than just stick. It heals. We will now explore further on how chiosmastic can help balance blood sugar. Chiosmastic helps our body respond better to insulin. How does this happen, you'll ask me? Well, firstly, it lowers fasting plasma glucose by making sugar easier to control. It slows down how quickly carbs turn into sugar after a meal. And moreover, it fights inflammation and oxidative stress, which are both major contributors to diabetes-related complications. In short, it supports our body in multiple fronts. Now, what about real science? Real people? A clinical study was done where we had 179 patients who had total cholesterol levels over 200 milligrams per deciliter. These individuals, they were randomized into 4 different groups. The first group was the control group, which received a placebo every day for just 8 weeks. The second group was the total mastic group, which received 1 gram a day of crude chiosmastic gum. The third group was the polymer-free mastic group, which received 1 gram a day of polymer-free mastic. This is a form of chiosmastic gum or oil that has had its natural polymers removed, focusing on its low molecular weight and active compounds such as essential oils and terpenes. Last but not least, the fourth group is the powder mastic group, which received 2 grams a day of crude Chios mastic gum. So now let's talk about numbers. In just 8 weeks, the total mastic group showed a significant reduction in total cholesterol by 11.5 milligrams per deciliter and fasting plasma glucose by 4.5 milligrams per deciliter. No side effects. Even better, overweight and obese individuals have an even more pronounced effect. They had reductions of 13.5 milligrams per deciliter in cholesterol and 5.1 milligrams per deciliter in fasting plasma glucose. Again, no side effects. So, we can come to the conclusion that Chios mastic gum has a significant lowering effect on total cholesterol and glucose levels, especially in overweight and obese patients. Here we can see a diagram which shows the effect of Chios mastic gum compared to a placebo on various blood markers over an 8-week period. It visually presents mean values for total cholesterol, LDL cholesterol, HDL cholesterol, triglycerides, and glucose. The key findings of this diagram clearly show us that the total cholesterol and the LDL cholesterol are significantly lower in the Chios mastic essential oil group compared to the placebo group. All parameters show statistically significant improvements after just 8 weeks of CMO supplementation. Now, what does this mean? For all the aforementioned reasons, we can say that Chios mastic is a powerful ally, a natural supplement that could support conventional treatment. But further studies are necessary to document lowering of glucose levels. While it shouldn't replace conventional treatment, it might serve as a complementary therapy. It's time we stop seeing nature and medicine as opposites, because together they can offer a more complete solution. Peer-reviewed studies from European journals have confirmed the results. We hope to contribute to relevant clinical research in collaboration with Professor Andreas Gialouris, Professor Sofia Themistokleous, Professor Katerina Menelau, and Dr. Kartalis at Skilichion General Hospital of Chios. So the next time you hear about Chios mastic gum, do not think of it as just gum, but as a special and precious ally to our work. Thank you very much for your attention. Do you have any questions? Yes, of course.
Were there ever studies done on how much someone should consume in order to have a proper effect on glucose levels?
Well, we saw at the clinical study that there were 4 groups. Each group, you can see how much they received every day for 8 weeks.
And could you explain the pathophysiological pathway that the mastic gum follows? Or is it like are there multiple molecules involved? How does it work exactly?
Well, let me see. As we mentioned here at the mechanisms of action, we can see that it reduces fasting plasma glucose and potentially eases glycemic control. It inhibits aglucosidase activity and slows down carbohydrate absorption after every meal, which means that it helps with the sugar in our body. And it suppresses pro-inflammatory cytokines and modulates oxidative stress, which are both major contributors in diabetes-related complications. Does this cover your question? Thank you. Are there any other questions? Yes. Well, we have started a research in both Greece and Cyprus, and it will start in the following months about how CAMeSM can help with diabetes, and it can be used as complementary therapy treatment. But this research is still in the beginning, so if we have more statistics and more information, we will create a site and we will inform you about everything that we find. Thank you very much.
Thank you, Katerina, for the interesting presentation. Now we will move on with the next speaker. We have Emilia Lis with the title Life-Saving Flow Retriever Thrombectomy in Acute Pulmonary Embolism.
Okay, hello everyone. Thanks for the opportunity to present you a case about the thickening thrombus and the life-saving flow retriever thrombectomy. My name is Emilia Lis and I'm representing European University Medical College and Pulmonary Circulation Center in Kraków, Poland. But first, let's recall together some most important information about acute pulmonary embolism, because I'm sure you are all familiar with pulmonary embolism cases, as this is the third most frequent cardiovascular incident globally, where the thrombi blocks the flow through pulmonary arteries, leading to acute right ventricle overload. And then, based on the signs of right ventricle dysfunction and hemodynamic instability, we can divide patients into three groups of low, intermediate, and high risk of death. And today we'll be analyzing case of a low-risk group patient. However, it's still very life-threatening condition requiring urgent treatment. So what options do we have? EST guidelines suggest that for low-risk, stable patients, we should proceed with anticoagulation therapy. Meanwhile, for more hemodynamically unstable patients, we fluctuate between systemic thrombolysis and interventional methods, either surgical or percutaneous. We do it all to improve patient poor prognosis. And then there is this condition that can worsen the prognosis even more, the presence of the right atrial thrombus. And now I have a question for you all. How many of you have seen or have met a patient with right atrial thrombus? Have anyone seen something like that in the right atrium? Okay, I don't see anyone, and that's not a surprise, because fortunately, right atrial thrombus is quite rare finding, occurring in about 10% cases of pulmonary embolism, yet you should always consider it in the diagnostic workup, as it can bring a mortality rate of even 40%. If left fully untreated, even 90%. So why that's high? Because in case of right atrial thrombus, you have to keep in mind that any moment the thrombi can embolize further, causing total pulmonary arteries occlusion, or in case of presence of patent foramen ovale, so a septum between septum between the atria, it can cause stroke or intestinal ischemia. So basically, this is a very dangerous condition requiring our urgent action. Yet the optimal management is still not well established. So we don't have clear guidelines on how we exactly should treat this group of patients. So as we know for now, in case of right atrial thrombus, it's all about the individual assessment of the patient based on his clinical status. So now when we are more familiar with the characteristics and risks of right atrial thrombi, we can move on to the case report. So the story starts in the emergency department, where the 37-year-old woman presents with dyspnea and worsening exercise tolerance for about a week. She also has a persistent cough after respiratory tract infections 2 months before. She's a healthy woman with no comorbidities, yet I think some risk factors have already drawn your attention, because she's an overweight, she's a smoker, and she uses oral contraceptives. Upon physical examination, she has sinus tachycardia with nice blood pressure and saturation, yet with highly elevated dimer levels. So it's no surprise that pulmonary angiogram CT confirmed the presence of acute pulmonary embolism in that patient. And if you remember the table I showed you in the introduction, looking at our patient who is hemodynamically stable with no signs of right ventricular dysfunction, she can be classified as a low-risk pulmonary patient, even though pulmonary angio CT revealed almost total occlusion of the left pulmonary artery. But according to guidelines, she starts anticoagulation therapy with low molecular weight heparins. Meantime, of course, echocardiography is performed. And here, structure in the right atrium is visualized, measuring around 20 millimeters, hanging on a thin stalk in the area of the crista terminalis. And I couldn't successfully upload the video to my presentation, so I brought it right here with me. So I hope anyone of you can see that, how mobile the structure really is, literally ballotting in the right atrium area. And what we can see and think about this structure is that it has a high risk of embolization. So you can now imagine you are the doctor in the ER and you see something like this, and just think, what would you do in such situation? Because in Poland, we have a multidisciplinary team called the Pulmonary Embolism Response Team that is dedicated for the more complicated and severe cases of pulmonary embolism. And as we know, right atrial thrombus is definitely such a complicated situation. So here a consultation by PERT team was ordered. And once again, you can imagine you are those doctors and you don't know the title of my presentation because they clearly didn't know that by then. And can you be 100% sure that thing you see in echocardiography is a thrombi? Well, most possibly, but maybe it's a kind of a neoplasm, a tumor, or infectious vegetation. It's all possible. So here we definitely need more imaging. So the first thing the PERT did was to order the contrast-enhanced cardiac MRI. But here, a surprising contraindication to urgent cardiac MRI occurred, a tongue piercing. And you may think, what's the problem? Just remove it and rush patient to the MRI. The problem is that this piercing had already grown into the tongue of this patient, probably due to poor hygiene, and couldn't be easily removed. So a problem here because the patient was already in the cardiology department, so no surgeons here. But fortunately, the PERT team doctor was able to remove the piercing with a small surgical cut, as it was covered only with a thin tissue layer. But I mentioned this situation to highlight that even during highly specialized fast-track diagnostic workup, we should examine the entire patient because surprises like this can occur anytime and they can surprise us and complicate our situation. But after urgent piercing removal, patient underwent the cardiac MRI that confirmed that the thing we saw in echocardiography was actually a thrombi, measuring around 21 millimeters, hanging on this thing, so really mobile structure. And also, additionally, here on the last photo, you can see the massive pulmonary embolism in the left pulmonary artery. Okay, so what now? We know that thrombi has a high risk of embolization. We have to do something. Should we proceed with anticoagulation? Yes, we already started that. The thrombi persists, so we need something more. So maybe systemic thrombolysis. It's an option, but with the risk of major bleeding complications. So maybe cardiac surgery. Yes, it's another possibility, but we have to remember that cardiac surgery is a massive surgery, and this is very young women. So all of these options include their limitations, and it's all about the risk to benefit ratio. And in that case, the PERT team decided on the thrombi removal with the minimally invasive percutaneous thrombectomy using the FlowTriever system. A system that provides a minimally invasive procedure in which a catheter is inserted percutaneously through right femoral vein. It goes to the area of the thrombi, which is then aspirated using negative pressure. The whole procedure is under fluoroscopic and transesophageal echocardiography guidance. And even though the FlowTriever aspiration thrombectomy is dedicated for the removal of the thrombus in pulmonary arteries, it could be used in that case of right atrial thrombi with the mother and child technique. So basically in this technique we use two large catheters, one larger 24 French mother catheter and the smaller 20 French child catheter. So basically the bigger catheter stabilizes the smaller one, and that allows for safe and effective thrombi aspiration. Unfortunately, whole procedure was uneventful. After all, the atrium was free of thrombus. The patient had improvement in clinical status and in her echocardiographics. And do you think is this the end of story for such patient? Of course not, because here we have a case of a young woman who suffered a massive thrombotic incident, so she is a thromboembolic risk patient. She needs further assessment. So upon discharge, we continue her mechanothromboprophylaxis. As for further anticoagulation, she will receive rivaroxaban. While waiting for the results of thrombophilia screening, she has to visit her gynecologist, vascular specialist, and after 3 months, she will go to cardiologist to assess the effectiveness of anticoagulation therapy. And to conclude, in case of right atrial thrombus, which is rare but underdiagnosed, potentially hazardous phenomenon, even though patient is initially clinically stable, we should consider the risk of thromboembolization that can cause total artery occlusion and can deteriorate patient condition. That requires our urgent action. And in that case, minimally invasive percutaneous thrombectomy using the FlowTriever system proved to be safe and effective way of right atrial thrombi removal in acute pulmonary embolism patient. And at the end, I want you to leave you a little bit more relaxed after my presentation with the nice view at the beautiful mountains and the citation by Nelson Mandela, who once said that it always seems impossible until it's done. And that's basically a message for us students, because we have to remember that in a few years, in the future, it will be our job to take on the challenge in such cases to find, learn, and initiate new treatment methods to improve patient prognosis. And then we have to remember that if we want to have new good outcomes, we actually have to make them first. As for now, thank you so much for your attention. If you have any questions, you can ask me. Thank you. Okay.
So thank you very much, Emilia. Now we'll move on with the next presentation. We have the trach valve for tricuspid regurgitation by Klaudia Sadzinska.
Ladies and gentlemen, my name is Klaudia Zaczyńska, and today I'm honored to present you case reports, option for no option, trach valve for patients with hemodynamically relevant tricuspid regurgitation, and my affiliation is Pulmonary Circulation Center in John Paul II Hospital in Kraków, Poland, Jagiellonian University Medical College. So let's start with the introduction. Severe tricuspid regurgitation presents the clinical challenge, as it is predictive of poor survival, especially if left untreated. Unfortunately, the medical therapy consists mostly on diuretics and has limited efficiency because of the pathomechanism of how it works, and it only alleviates the symptoms comes from. And the clinical sequela which we can approach is right heart dysfunction, peripheral edema, and liver congestion. And as we know, many patients are ineligible for traditional surgical treatment or edge-to-edge repair interventions, and sometimes those interventions are contraindicated with comorbidities that patients have. So here is the picture of TEER, transcatheter edge-to-edge repair of tricuspid valve, which is quite common in Poland. It's the first line after the surgical treatment of regurgitation, tricuspid regurgitation. It's in our guidelines, but sometimes when we are not allowed to perform such kind of transcatheter procedure, we need to focus on symptoms, and we need to focus on maybe sometimes not to repair the valve, but how to alleviate the symptoms and how to improve hemodynamically the patient. So from some years, there was a shift in cardiology, there was a shift in treatment strategy towards as much minimal invasive as we can. So now let's talk about transcatheter solutions that focus not only on valve replacement, as I said before, but also on modulating flow dynamics in patients. One of this treatment is caval valve implantation, which targets venous reflux and reduce right-sided heart failure caused by this severe tricuspid regurgitation. And the system, I will show you in next slides how it works, but just to have a short look up on the system, is designed to relieve the symptoms by preventing backward flow without replacing the native valve. And what's the system? So as you can see, superior and inferior vena cava, and we implant two self-expanded biological valves. It's important that those valves are biological, and we don't interfere with the native patient's tricuspid valve. Also, we need to emphasize that it's option for no option candidates who's been disqualified from both surgical treatment and trans edge-to-edge catheter treatments. So here is a valve, and it's made of bovine pericardium, and as you can see, short skin and large skirts, because to prevent hepatic vein occlusion. For example, in this case, because it's implanted in inferior vena cava, and this one is implanted in superior vena cava. So let me now move to case report. It's our patient who had this trick valve implanted. And we'll focus on 81-year-old male with massive tricuspid regurgitation, atrial fibrillation, chronic heart failure, chronic renal failure, and diabetes. As you can see, the patient undergone multiple interventions. It was percutaneous aortic TAVI valve implanted called TAVI for severe aortic stenosis in the past, also mechanical mitral valve prosthesis, and also leadless pacemaker because of the palpitations. And as you can see, despite the well-balanced pharmacotherapy, because anticoagulants, warfarin, diuretics, furosemide, torsemide, and big five for heart failure, including dapagliflozin, as you can see, bisoprolol, ramipril, eplerenone, flozin, and atorvastatin, the patient still had complications of its condition, and he was disqualified from both cardiac surgery and percutaneous treatment. As I said to you before, that are the first line, and when we talk about the patient with tricuspid regurgitation. And the patient was admitted to the cardiology department. He presented with New York Heart Association 3 class symptoms like exertional dyspnea, lower limb swelling, abdominal distension, and also occasional palpitations. So if you imagine a patient with heart failure, it doesn't matter left or right heart failure, it's the patient, as you can see. And his NT-proBNP levels were high, his kidney parameters were low because of acute chronic kidney disease. He was also body plethysmography performed, which showed restrictive ventilatory impairment and reduced diffusion capacity for carbon monoxide. And here you can see echocardiography, and on this illustration you can see aortic valve implanted in this is a short axis view. Here you can see right atrium, left ventricle, right ventricle. And here you can see inferior vena cava, which size is 30 millimeters, so it means that it's dilated, and collapsibility is less than 50%, so it means that we have high pressures in right heart. And here you can see jets, which means it's right atrium, it's right ventricle, and left side of the heart. And the jets means that we have severe tricuspid regurgitation. So some parameters, its ejection fraction was normal, but it was heart failure with preserved ejection fraction, and big right atrium area because the norm is up to 18 centimeters, and the size of the right ventricle is also big. As you can see, high pressures, and as I said before about inferior vena cava measured in echocardiography, here you can see outflow of right ventricle, so it's dilated. The patient also undergone right heart catheterization, and the conclusion was that the patient also had postcapillary pulmonary hypertension with increased right atrial pressure. So if you remember from your clinical words, pulmonary hypertension is also contraindicated in when we think about new hearts to these patients, about transplantation. And what's next? So we need to gather a multidisciplinary heart team, and the heart team consists of cardiologists, interventional cardiologists, cardiac surgeon, anesthesiologists, and any other specialists that are required to evaluate the whole patient. So in this case, it was also nephrologists, and they recommend to implant percutaneous bicaval valve system called trick valve. And some words about the procedures. And the valves were successfully implanted in the superior and inferior vena cava. without disturbing the native tricuspid valve, and the procedure was uneventful and went all right. So this is the system that we perform transfemoral access, and just few minutes after the procedure, there was a radical center venous pressure reduction, and also elimination of vena cava reflux, because during the procedure there is also a guide, a catheterization of the heart, and we can evaluate and measure the pressures in right atrium. So here is the picture of future, but maybe picture of nowadays, because you can see how many things this patient has inside. Let's start with the newest one. It's trach valve, superior inferior vena cava, and catheter. So here is the probe of transesophageal echocardiography that was during the procedure performing. Here you can see aortic valve, artificial, that was implanted in the past. Also mitral valve prosthesis implanted in the past. And here you can see leadless pacemaker. So many things in one patient that can help him to have normal life. So during the follow-up visit, the patient said that there was a reduction of acids, as we can also see, and there was an improvement in exercise tolerance. And to sum up, we have to emphasize the role of minimal invasive interventions in managing not only severe tricuspid regurgitation in high-risk patients, but also in all high-risk patients that can get something new without complications. And this system, this trach valve system, provides viable alternative by reducing venous congestion and addressing the hemodynamic consequences of right heart failure. So we as a medical student need to remember, need to see these procedures, need to be aware that those are things that are going to be done, and they are also now doing, I think, in your universities, in your hospitals. Thank you for your attention. Thank you for invitation. If you have any question, I will be glad to answer. Thank you.
Now on stage is Aphrodite Persephone Pascoe presenting AI in breast cancer imaging for dense tissue, a cutting-edge talk on diagnostics and digital innovation.
Hi guys. Just need to. No. I always get so anxious at these sort of things. So if I pass out, at least I have a room full of future doctors to help me and resuscitate me. But good afternoon, good morning, everyone. My name is Aphrodite Pascoe. I am a third-year medical student here at EUC, and I'm interested in hopefully one day becoming an oncologist with a keen interest in women's cancer. So, for this reason, my presentation today is titled Artificial Intelligence in Breast Cancer, specifically imaging for dense breast tissue. I'm sure we all know by now that breast cancer is the most common cancer affecting women worldwide. It's also the most common cancer worldwide, period. And it's also the 5th leading cause of cancer-related deaths. For this reason, it is a massive discussion point in medicine. Now, breasts have different percentages of density, and every woman is obviously different. And women with dense breast tissue have more fibroglandular tissue than fatty tissue. And this is present in about 40% of women. So that's a good chunk of the population, I would say. But however, having dense breasts creates unique diagnostic challenges. Why? Well, I hope that we're going to find out with this presentation. Moving on, artificial intelligence. I know we all love it. I love it. I use it every single day. But it's not just a tool that medical students use to study. it's a revolutionary tool that's used currently in breast cancer imaging, and not just breast cancer, all types of cancer. And it's especially helpful for women with dense breasts. Why? Again, we shall find out. So I already explained what dense breasts are, more fibroglandular than fatty tissue. But why does this tissue type make it harder to interpret mammograms? Well, dense tissue appears white on a mammogram. And you know what else appears white? Does anyone have any idea? Well, it says it on the slide, but tumors, malignancies, they also appear white. So, and also regardless, dense breast tissue is an independent risk factor for cancer, but for breast cancer, but that's a discussion for a different time. Now, here we see a diagram showing the different percentage of densities. And as you can see in picture A, the breast appears much clearer. But with picture D, there's a bit more chaos. And I'm sure you can guess that D is more dense tissue. Now, here's another really fun picture. On the left, we have circled a malignancy in a not dense breast. But let's pretend for a second that the red circle was not there, okay? You, as students, would be able to see the malignancy clearly, right? I hope so. But on the right picture, where the breast is more dense, without the circle, to us students at least, would it be so easy? I don't think so, at least for me. Okay, but here's my question to myself, but also to you guys. How can artificial intelligence help? AI can help diagnose malignancies through various ways. Firstly, enhanced image analysis. AI can detect even the smallest changes within dense tissue. Second, improved accuracy. So I want you to picture this for a second. You're a really tired first-year resident, and you've just completed a 24-hour shift. How easy would it be for you to make the tiniest simple mistake and miss a malignancy within dense tissue? I don't think it would be that hard to do that. AI can't get tired. It doesn't need coffee to survive. I definitely do, but. And third, support for radiologists. AI can serve as a second reader, a radiologist's personal assistant, their own built-in second opinion without having to leave the comfort of their dark, quiet room. And lastly, AI works with all imaging modalities. It's not held back by just one. It can receive images from every type: ultrasound, X-ray, MRI. But, and please, if you're going to listen to me for once throughout this presentation, listen to this. AI cannot replace doctors, hopefully anyway, because then we wouldn't have a job in the future. But instead, it will augment them, augment their already existing capabilities, their already existing experience, education. So, for breast cancer diagnosis specifically, there's many different AI models that are currently being used as we speak. I made this research a few months ago, so maybe some things have changed. But in the literature, the most common ones I found are Google Health's DeepMind, Transpera, and iCAD's Profound AI. But what about for the country of Cyprus? I became a detective, and I looked through as many diagnostic centers in Cyprus as I could, and I could not find one that advertised using AI openly in their website. I did find a startup company that's called MammoCheck, and they're advertising that they're going to be using thermography guided with AI, but there's really not enough info on their website for me to feel confident enough to explain more about it to you guys. So if you're interested, just check their website. It's MammoCheck. So now, how do these models work? I showed you guys the models, now I want to show you how they work. But that's really hard to explain in 10 minutes. And I asked my colleague Alex to try to explain to me how it works. He's really tech savvy, but it just sounded like he was saying a different language. So I'm going to try as best as I can, so bear with me. And if you have any questions, please feel free to stop me at any moment. Step 1, input data. We take an image, we put it into the model, and the AI system is trained on existing images of MRIs, ultrasounds, whatever we put into it. So we label images with either a score or if they're malignant or not, and we give it to the to the AI model. So we input an image into it. Step 2, processing. So AI doesn't really see kind of like humans do. It breaks down images into mathematical features such as texture patterns, shape, and margin of lesions, mass density, etc., etc. There's so many different types. Step 3, model training. So the AI has shown millions of images, each image labeled as malignant or non-malignant, like I said in the start. And over time, the model learns to associate patterns in the image with actual diagnoses. Step 4, the prediction phase. This is where we input a completely new image into the model, so one that it's never seen before. And the AI runs it through the trained model that we've trained by inputting already existing images. And then we move on to the last step, step 5, which is the output. Then AI gives a risk score of malignancy or a probability of malignancy. And it also can highlight regions of interest for radiologists to go over and look at them specifically. Now, there are some ethical considerations that we have to consider, bias being one of them. AI systems are only as good as the data that we give to them. So if we don't give them enough data, if we don't give them well-rounded data, it will be biased. Not every cancer is the same, not every patient is the same. Consent is another consideration. AI is really, really new, especially in healthcare, its use in healthcare. So a lot of patients with breast cancer are older and they might be intimidated and maybe even scared. So informed consent is very important. Also for privacy concerns, because we do input patients' personal medical information somewhere that potentially could be hacked, you don't know? So yeah, consent is very important. And lastly, over-reliance. So is it really, really an issue? I like to be as optimistic as possible because I've met some amazing physicians at CAMeSM this year, and I'd like to think that they wouldn't rely just on AI blindly. But alas, the literature all talks about this as being a risk, so I definitely wanted to mention it. Okay, lastly, we have some practical considerations as well. How easy is it really to integrate AI into healthcare systems? It takes time. We have to be trained on how to use it. Training costs money. So how easy is it? Also, who can't and can access it? I guess this can also be considered an ethical issue. Would the high cost limit AI accessibility to those in low resource settings? I don't like to talk about fairness in medicine, but who says that a woman in Africa or in a low resource setting that doesn't have the resources to apply AI, why does she not get to have this service, but people here can? But again, that's a different discussion, but yeah. And lastly, regulatory standards. Who approves these things? Cyprus doesn't have any regulatory guidelines regarding AI integration in healthcare. At least I couldn't find any. So how can I, as a future doctor, know if it's even legal to use this on patients? Thank you so much for your attention, guys. If you want to read my article, you can scan. And I'm open to any questions. Nope. Okay, well, that means that my presentation was amazing or it was really bad. So thanks, guys. Thanks so much.
Next, we invite Ioana Daria Paval to the stage. Her presentation, An Uncommon Case of Rectovaginal Fistula Due to Extrapulmonary Tuberculosis, brings together rare pathology and clinical insight.
Hello, esteemed colleagues. My name is Ioana Pavel, and I'm a fifth-year medical student at the University of Medicine and Pharmacy Iuliu Hațeganu in Cluj-Napoca, Romania. And today I'm going to present an uncommon case of rectovaginal fistula due to extrapulmonary tuberculosis. Okay, I will begin my presentation with some theoretical aspects regarding the pathologies in this case report. Firstly, the anorectal tuberculosis is a rare form of tuberculosis, and it is very difficult to diagnose, underlining the importance of differential diagnosis with other pathologies of the region, such as Crohn's disease. A positive diagnosis is established by a mandatory histopathological examination of the excised fistula. The most common symptoms and clinical signs are tenesmus, abnormal discharge, suppurations, adenopathies, and the most common one being anal fistula. And lastly, rectovaginal fistula is a pathological epithelialized tunnel through the rectovaginal septum caused more frequently by iatrogenic errors, diverticular disease, and inflammatory bowel disease. Okay, so our patient was a female of 41 years old, known with a medical history of pulmonary tuberculosis confirmed through X-rays, CT, and histopathological examinations of the sputum, 2 births through C-section, smoking with a 25 Becquerel's index, and essential hypertension. She presented in our service in September 2023 with lumbar pain and loss of appetite, narrow stools with rare blood spots with, who began 3-4 months prior of the consultation, and the most disturbing symptom being sudden fecaloid vaginal discharge. The doctors decided to treat her conservatively through a temporary lateral baguette sigmoidostomy in the left iliac fossa. In May 2024, we performed an MRI examination, which revealed scar tissue in the lower rectum, stenosis, but no visible fistulous tracts. You can see the affected area pointed by the red arrow. In the figure 1, we have an MRI in T1 ponderation, sagittal plan. In figure 2, we have an MRI in T2 ponderation, sagittal plan again. And in figure 3, we have an MRI in a transversal plane in T1 ponderation. After the examinations, the positive diagnosis was rectovaginal fistula complicated with a complete lower rectal stenosis caused by anorectal tuberculosis, which was confirmed by the presence of a caseous nodule in the rectovaginal septum. The doctors treated our patient in June 2024 through an ultra-low anterior resection of the rectum with a mechanical terminal coloanal anastomosis, and the operatory steps were the following ones: explorations of the region with an attempt to mechanically dilate the stenosis, but with no success. After they performed a median abdominal laparotomy, the dissection of the mesorectum and the sigmoid mesocolon using a ligature in order to isolate the superior rectum, the transection of the superior rectum from the stenosis area, and finally a mechanical terminal coloanal anastomosis with a circular 28 millimeters covidian. And in order to assure the drainage, they inserted 3 drainage tubes. In conclusion, our patient's evolution was favorable, being discharged with present bowel movement, a clean surgical wound, and the remaining baguette colostomy in the left iliac fossa. The surgical solution involved an ultra-low rectal resection with coloanal anastomosis, keeping a protective stoma in place with a very good outcome at 5 weeks postoperatively. We consider that it is very important to present this case because due to the lack of similar documented cases in the literature, therefore being a unique case of anorectal tuberculosis. My references and acknowledgements to the scientific coordinator, Ciprian Cucreanu, MD, PhD. Thank you. If you have any questions. Okay. Thank you.
Our next speaker is Pantili Razvan Gabriel with a fascinating case report, Synchronous Duodenal and Cecal Adenocarcinomas, a journey into an uncommon diagnostic challenge.
Hello everyone, my name is Advan Gabriel Pantilier and I'm a fifth-year medical student at Iuliu Haziganu University of Medicine and Pharmacy. And today we're going to explore an unusual case of asynchronous duodenal and cecal adenocarcinoma. First of all, let's look a bit at the particularities of each type of cancer. As we see here, the duodenal adenocarcinoma is, they tend to be more rare and more aggressive. And an explanation to this can be resided in the fact that in the duodenum, the bacteria is less diverse, and therefore the oncogenes, the oncogenetic process is not as amplified as in the colon. As for the treatment, both of those cancers are treated definitely with surgery, but the surgery itself varies with the location of the cancer. Another thing they have in common are the risk factors, such as molecular genetic changes and pre-existing conditions such as Crohn's disease and adenomatous polyps. Now let's take it to the start, where we have a 52-year-old male who presents with asthenia, weight loss, dyspeptic syndrome, and hematochezia, progressively developed over a year. And on clinical exam, we found a firm mobile mass of about 4 centimeters in the right flank of the abdomen. We suspected a digestive tract adenocarcinoma, so we took it to the next step, to the imaging, where we did a computed tomography, a magnetic resonance imaging, and upper and lower digestive endoscopic ultrasound with biopsy. And after all the results, we got the conclusion of a stenotic duodenal adenocarcinoma, located at D3, D4 level, and stage T was followed, and the cecal adenocarcinoma stage was followed. Neoadjuvant chemotherapy treatment was started 8 months prior to the surgery, initially with 3 cycles of Folfox, which is folinic acid, fluorouracil, and oxaliplatin. And I have a CT here of the preoperative assessment, and I don't think it shows. No, it doesn't work in the video. But we saw an enlargement of the mucosa both in the duodenum and in the colon. Under the chemotherapy treatment, unfortunately, it wasn't effective, and the duodenal tumor remained stable, and the cecal tumor even increased. There was also an episode of a sudden gastric outlet obstruction secondary to the duodenal adenocarcinoma. And I want to remind you that it was diagnosed as stenosing duodenal adenocarcinoma even before the evolution. So an emergency site-to-site gastroenteral anastomosis in omega loop, in omega loop configuration, anticolic had to be done. And because of the ineffectiveness of the treatment, it had to be changed to a Folfoxiri protocol with the addition of irinotecan, of which 3 more cycles were administered. Now for the surgical part, we did an extended right hemicolectomy with isoperistaltic side-to-side ileocolic anastomosis and D3 lymphadenectomy for the cecal adenocarcinoma, and for the duodenal one, we did a segmental resection of D3, D4 duodenum with ventoside duodenal jejunal anastomosis and FIDIC jejunostomy. The postoperative gastrointestinal tract configuration thus resembles a Roux-en eye, with the limb formed by the duodenal jejunal anastomosis, because the patient had a previous bill of 2 configuration anastomosis from the emergency operation that had to be done on him. Discharge in good general condition, without any fever, with resumed intestinal transit for liquids and solids, good food tolerance, and a clean surgical wound healing by primary intention. I chose this case because even though the treatment was quite as protocol for gastrointestinal cancer, it didn't really work. Because, first of all, there is a great variety of double gastrointestinal localizations of 2 types of cancer. There is no established consensus on guidelines. Thus, we treated them as usual adenocarcinomas of the gastrointestinal tract with the chemotherapy Folfox and Folfoxiri, which were ineffective. So the question that has to be raised is whether we could go to another treatment method, such as immunotherapy or even genetic methods of treatment, which takes me to my 4th point of discussion, the genetic testing. We know that there are multiple genes involved in the oncogenesis of this type of cancer, such as P53 or KRAS, and we could try some type of treatment there. And there is also the discussion of the surgical treatment for the duodenal area, where the standard for a lot of time was pancreatic duodenectomy, but it was shown in multiple studies that it has a higher morbidity and higher occurrence of side effects. So limited resection is preferred there. And thank you everyone for your attention, and if you have any questions, I'm glad. Thank you. Yes.
What rationale guided you to give preoperative neoadjuvant chemotherapy?
Because the duodenal tumor was stenosing, and we wanted to, we didn't want things such as wait, let me just show you. Yes, we don't want the gastric outlet obstruction to happen, and we thought that maybe with the standard protocol for this type of cancer, we could reduce the possibility of this. But because of its ineffectiveness, it didn't work, and the patient had to get an emergency operation. Yeah, thank you.
Please welcome Lulia Cesara Pop, who will speak on treating recurrent liposarcomas and giant incisional hernia, an inspiring reflection on surgical resilience and recurrence.
Okay, greetings, esteemed members of the jury and fellow students. My name is Iulia Cezara Pop, and I'm a fifth-year medical student at Iuliu Hațeganu University of Medicine and Pharmacy, Cluj-Napoca, Romania. Today, I would like to present a case report of a male patient that was diagnosed with retroperitoneal liposarcoma and giant incisional hernia. Retroperitoneal liposarcoma is a rare malignancy that poses a challenge for early detection and diagnosis. The prognosis is contingent upon the tumor size and its histological subtype, but also whether the metastases are present or not. The incisional hernias occur in 11 and 23% of laparotomy patients, and the repairs mostly address the defects that are larger than 15 centimeters. Okay, a 15-year-old male patient presents to our surgical department with an enlarged abdomen due to a recurrent retroperitoneal liposarcoma. On physical examination, a giant incisional hernia is observed. For the relevant medical history, the patient was previously diagnosed in 2016 at a distinct medical center with a well-differentiated retroperitoneal liposarcoma and received surgical treatment. The surgical resection piece weighed about 6 kilograms. The tumor recurred in 2021, and again the patient underwent surgery, but this time the surgical intervention was more complex, and the resection piece weighed about 10 kilograms, and an appendicectomy and partial epiplanectomy were performed. The patient had multiple comorbidities, including chronic kidney disease, mild obesity, and bilateral obstructed ureters. The CT showed a retroperitoneal tumor, a midline abdominal defect, and a 7-centimeter elevation of the right hemidiaphragm. The paraclinical investigation showed high levels of creatinine and urea, which are consistent with the patient's chronic kidney disease. surgery is performed for the giant incisional hernia and for the recurrent retroperitoneal liposarcoma, with an unblocked excision of the tumoral mass. One unique aspect of this case is that we found a retroperitoneal tumor that measured 45 per 35 centimeters and weighed about 20 kilograms, which encased the right kidney, the terminal ileum, the ascending colon, and right anterolateral peritoneum. Therefore, we performed, along with the unblocked excision of the tumor, the excision of the right hemiabdomen parietal peritoneum, and also right nephrectomy, extensive right hemicolectomy with end-to-side iliotransverse anastomosis, and the incisional hernia repair was done by an onlay technique with a lightweight macroporous polypropylene prosthesis measuring 30 per 25 centimeters. And here you can see the resected specimen and the abdominal wall reconstruction. For discussions, in this case, because of the patient's high risk of bowel obstruction and eviscerations due to the giant incisional hernia, and due to the pulmonary compression caused by the tumor, the indicated course of treatment was the surgical one. The prognosis is favorable, but the patient has high risk of tumoral recurrence. The patient started alimentation on the first day post-op, and the intestinal transit was reestablished on the third day post-op. He was encouraged to participate in active movement and in respiratory kinetotherapy, and he was discharged on the seventh day post-operative in a good general state with present intestinal transit and a healing abdominal wound. Therefore, the evolution shows positive signs. In conclusion, the best course of treatment for these cases of tumor is the surgical resection. With a good surgical resection, the 5-year survival rate lowers, and which is very important for the patient. The disease-free rate is about 34%, and it's influenced by the tumoral grade, the resection margins, and the vascular involvement of the tumor. Thank you very much.
Now on stage is Maria Kurian with a rare and challenging case, cirrhosis with ectopic variceal bleeding. Let's take a deep dive into hepatology.
Hi, good morning, fellow students. Thank you all for your wonderful presentations, and thank you for having us here. My name is Maria Kurian. I'm a fifth-year medical student from Transylvania, Romania. I'm going to present to you a really fascinating case, in my opinion, of a salvage transjugular intrahepatic portosystemic shunt in a rare case of cirrhosis with ectopic variceal bleeding. So, transjugular intrahepatic portosystemic shunt, for short, I'm going to call it TIPS, as I'm sure all of you know this abbreviation. So, has anyone heard about this procedure before? What do you know about it? When do you use it? Can you give me just one example of when you'll be using a TIPS, for example?
Cirrhosis.
What complication of cirrhosis exactly?
Hypertension.
Yeah, and what complication exactly?
It depended from where we were reading from, but some encephalopathy or
Hmm? no, we're gonna see that later. It keeps causing encephalopathy. We use it when we have bleeding, especially variceal bleeding. Okay, so this is the most common complication, especially in cirrhosis. You have the variceal, typical esophageal bleeding. But today we're gonna have a really rare case of periduodenal varices, and we're gonna hear about it later. Okay. So the general data, we have a 28-year-old patient, female patient, who has several pathologies. So she's known with Down syndrome, hemochromatosis, diabetes, autoimmune liver cirrhosis, also hepatic steatosis. So she already has a case of cirrhosis, Child-Pugh A, if you're interested, and also several heart pathologies that I'm not going to delve into. Okay, so why did she come to the ER? She was hemodynamically stable, and she presented for melanic stools. She had a BP of 130/62, pulse of 98, and SATs were all good. So hemodynamically, she was okay. The abdomen was mobile with respiratory movements and without tenderness to palpations, and overall she was fine. Rectal examination, though, was performed, and it revealed traces of melena. From a lab perspective, the blood test revealed that she was moderately anemic, so she had a hemoglobin of 9.1. She was leukopenic, also thrombocytopenic. She had hepatic cytolysis syndrome, bile retention, hypocalcemia, and a lot of other things, but these are the main ones. We obviously did an ultrasound, the bedside ultrasound, which revealed a cirrhotic liver with slow hepatopetal flow through the portal vein and splenomegaly. The IVC, so the inferior vena cava, was also dilated, but without collapse. Good. So we did a UGE, so an upper gastrointestinal endoscopy, which revealed fragile mucosa and erosions, both to the esophagus and the stomach, but without bleeding. So the UGE was negative. But the patient was bleeding from somewhere because she was severely anemic, so her hemoglobin dropped to 8, and she began being hemodynamically unstable. But we managed to get the endoscope till D2, and when we did that, with the touch of the endoscope, it revealed a bit of bleeding. So it was positive in the duodenum, the bleeding. The suspected diagnosis was severe anemic syndrome with variceal bleeding, suggestive for her clinical presentations. Remember, she came for melanic stools. We did a further workup. We did obviously computed thermography, so CDA, with contrast, because we wanted to see where she was bleeding from, and it revealed large periduodenal varices with active bleeding, and also lots of vascular shunts. We're gonna see that later. So we had a shunt between the portal vein and the pancreaticoduodenal vein, and also between the right renal vein and the splenic vein. We're gonna see it on the CT later. Okay. We also did a portography, as I said, which discovered large shunts. You're going to see it. And what was super interesting was the fact that we did also liver angiography, and the portal systemic gradient was 3. So no portal hypertension. You would think, how is that possible? The patient was bleeding. How come the portal systemic gradient was normal? And we see later why. So as I said, these are the images. We can see there in the middle the active bleeding from the duodenum, and we can also see partially from here the large shunts. We can see it there, especially in the left region. I'm going to have another picture that I'm going to show to you. Also the large shunts, which we can see here. Alrighty. So final diagnosis and treatment. The final diagnosis was complicated liver cirrhosis with ectopic, as I said, periduodenal variceal bleeding, and we started treating it. We did endoscopic management, including glue injections with cyanoacrylate, but also we tried clipping and coil embolizations, and everything failed. The patient's condition started to worsen. She became severely anemic. She had a hemoglobin of, I think, 6 or 7 or something like that. And she started being really unstable. And what we did in the gastroenterology and hepatology department in our city, we did tips, rescue tips or salvage tips, as you know it, in a last-ditch effort to stop the bleeding. But unfortunately, although initially the patient's condition started she got better, 12 days post-operation, she developed one episode of 3-4 grade encephalopathy, and then she developed multiple organ insufficiencies, and she died 12 days post-operations of a cardiac arrest, obviously. So the, I think, interesting part is the discussions part. Diagnosis and treating varices is, especially ectopic varices, is really hard, especially when their location is not the common one, so not the esophageal varices. Especially when they're not bleeding, they're really hard to diagnose because no one is looking for them, and we start looking for them just when the patient starts bleeding. At the moment, there is no consensus of how to treat periduodenal varices, although their mortality lies at 40% and the risk of rebleeding even after tips is by 50%. So we don't know what to do. We don't have a consensus yet, and it deems future research, and we need protocols to have a tailored patient management. As I said, in our case, every other effort failed and we did a tips, but we have to be really careful when we use tips. As I said, the patient was hemodynamically unstable. She was thrombocytopenic, so we always have to think about these risk-benefits decisions. Also, we have to really take into considerations that tips has a lot of side effects, and in this case, the hepatic encephalopathy was, I wouldn't say fatal. She had like a lot of other comorbidities, but was really clinically important. So that would be it. If I would have to sum it up, just 3 take-home messages is the fact that, as I said, management of variceal bleeding is challenging and requires a multidisciplinary approach. So we need gastroenterologists, hepatologists, intensive care, anesthesiologists, radiologists, interventional radiologists, so a bunch of medical professionals. The accurate selections of patients undergoing tips is crucial, especially, as I said, to prevent the side effects as hepatic encephalopathy. And as I mentioned before, treating complicated liver cirrhosis requires a personalized and multidisciplinary approach. Thank you very much for your attention. And if you have any questions, I'm all ears. No? Okay.
Let's now welcome Cesara Pop, speaking on pituitary macroadenoma, a multidisciplinary approach, a case that exemplifies collaboration in clinical care.
Hello everyone, I'm Cesara Pop, a 5th-year medical student at Iuliu Hațegaну University of Medicine and Pharmacy in Cluj-Napoca, Romania. And today I would like to present a case of a pituitary macroadenoma, illustrating the importance of a multidisciplinary approach. So, pituitary macroadenomas are benign tumors measuring more than 10 millimeters in diameter that account around 1/3 of pituitary adenomas. Despite being benign, they have a high recurrence rate. They typically present with symptoms which relate to their mass effects, so this means headaches, visual impairments, and pituitary hormone deficiencies. Their progression can lead to the compression of the optic chiasm, the invasion of the sphenoid sinus, and in rare cases, to pituitary apoplexy. The effective management relies on the collaboration among endocrinology, ophthalmology, and neurosurgery departments. Our patient is a 64-year-old patient who presented for progressive diplopia, narrowed visual fields, and frontal headaches. On the physical examination, she was clinically stable, and on the endocrine examination, there were no pathological changes. Initial visual assessment suggested the visual field narrowing, and then the later perimetry confirmed the bitemporal hemianopsia. The rest of our general physical examination was within normal limits, so I think we can move on to the rest of the complementary exams. The endocrine profile revealed normal levels of cortisol and TSH, low levels of FT4, FSH, and LH, and a mildly elevated level of prolactin. These results suggest central hypothyroidism and diminished gonadotropins consistent with pituitary compression. The mildly elevated prolactin is more likely due to the stock effect of the mass rather than being secretory adenoma. The brain MRI revealed a cellular and supracellular mass measuring 40 by 26 by 36 millimeters with a heterogeneous signal and moderate contrast enhancement. In terms of anatomical relations, there was complete encasement of the right internal carotid artery and less than 50% contact with the left. It caused impression on the frontal lobes and mass effect on anterior cerebral arteries. And it caused compression of the optic chiasm and optic nerves and the impression on hypothalamus and third ventricle. The MRI, in summary, it suggests that there is an important invasion of the surrounding structures, and one of the most important things I want to underline is the compression of the optic chiasm and optic nerves, which explains the visual impairments that the patient presented with. For the recommendations and treatment, we started with a structured dietary and lifestyle intervention plan. The thyroid axis was supported with Eutirox, and the hyperprolactinemia was managed with Dostinex. The first line treatment is surgical. So a transsphenoidal partial resection of the pituitary adenoma was performed with a favorable postoperative outcome. Histopathology and immunohistochemistry confirmed the diagnosis of non-functioning pituitary adenoma. So the final diagnosis was non-functioning pituitary macroadenoma, thyrogonadal hypopituitarism, disinhibition hyperprolactinemia, and optochiasmatic syndrome. But as I said in the beginning of my presentation, these patients have a very high recurrence rate of the initial tumor. So we have to check up on them every 6 months. So in conclusion, they need a lifelong surveillance, including regular MRIs and endocrine profiles. We did one month after the surgery, where the levels of FT4 and prolactin were normal, and the low levels of FSH and LH persisted. This outlined the favorable outcome of the surgery after the partial decompression, and also it meant that the tumor has begun to shrink. However, at the 12-month follow-up, the patient has a mildly elevated prolactin level, which meant that the tumor has progressed again. 6 months after the surgery, the MRI showed a moderate reduction of the tumor. And on the other hand, after 6 more months, the MRI showed a slight increase in dimensions of the tumor, with renewed encasement of the right internal carotid artery, invasion of the right cavernous sinus, compression of the optic chiasm again, and intrasphenoidal protrusion. So even after a year, and after 1 year, the patient had changes in the endocrine profile and MRIs, which meant that the tumor has progressed despite its initial shrinkage. For the conclusions, pituitary macroadenomas do represent a challenge. Throughout this case, I can say that our multidisciplinary team was indeed essential. And the first-line therapy remains surgical treatment. And I will emphasize one more time that for these patients, the long-term follow-up is mandatory, since pituitary macroadenomas have a very high recurrence rate, despite them being benign. Thank you very much for your attention. If you have any questions, thank you.
Now on stage is Sebastian Romeo Pintilli discussing prognostic factors in bronchopulmonary cancer, an important take on cancer prognosis and prediction.
Hello, everybody. My name is Sebastian Pintilli, and just like almost most of you in here, I'm a fifth-year medical student from Cluj-Napoca, Romania, and today I'll be presenting you a little study I've done on prognostic factors for the progression-free survival of non-small cell lung cancer patients undergoing targeted therapy. And I know that is quite a long title, so let's break it down, and hopefully you'll go home today knowing just a bit more about oncology and about survival studies. So, first of all, for those of you who haven't studied oncology yet, you should know that lung cancer, or bronchopulmonary cancer, to say the full name, is the second most diagnosed cancer in the world, but due to its not so efficient treatment and later discovery, it is the most lethal cancer. It is thus important that we figure out how we can manage this cancer better, and my contribution was on prognostic factors. Histologically speaking, most cancers of the lung are non-small cell cancers, 85% of them, and the rest of 15% are called small cell cancers, and they have a different prognosis, different treatment, and they are not the scope of my study. In most non-small cell lung cancer, nowadays we can find at least one driver mutation, such as the ones I wrote in my slide here. EGFR, the epithelial growth factor receptor, which is present in up to 20% of all non-small cell lung cancer patients. ALK and KRAS, these three represent important prognostic factors by themselves because of one important thing. We have targeted therapies for these mutations. For example, EGFR, the receptor I was talking about, is a transmembrane protein for which we have drugs such as osimertinib, which is a targeted compound. It is not a monoclonal antibody. It is just a chemical compound which specifically binds to the mutated protein that the mutated EGFR gene codes and inhibits its function, and thus it does not allow the cancer cell to proliferate as much as it would wish. But before I move on to the practical aspect of my study, we should know why are prognostic factors important, because after all, usually the therapy of cancer takes the center stage. It's much more interesting to treat a disease than to think about how long the patient will live with it. There are four big reasons. First of all, knowing the prognostic factors, knowing what influences the prognostic of a patient gives you insights about what causes the disease, about the pathophysiological pathway behind the disease. So if you know what causes a disease to manifest differently, you may guess at what causes the disease and what influences the disease from behind. So that helps us in fundamental research. Second of all, if we know how to accurately predict the survival of our patients, we can conduct quality clinical trials so that the two groups that we compare in our clinical trials have the same prognosis. And in the same idea, depending on the prognosis, we will have most likely different treatment ways, depending on how much the patient still has to live, And lastly, of course, especially in oncology, it is important to be able to provide an accurate response when the patient will ask how much time they have left or how the disease will most likely progress in the foreseeable future. So prognostic factors, just like the treatment of cancer, just like the diagnostic of cancer, are also important. What I did was investigate the database of our Cluj-Napoca Oncological Institute, where I found 79 patients that began treatment with osimertinib, that targeted EGFR inhibitor that I talked about earlier, beginning from November 2020 all up to October 2024. There was no available data from before. These 79 patients were included in one big database where I collected all the available data about them, all the data that I could find about them. Specifically the mutation exon, which is where in the gene exactly the mutation took place. The level of if there was a mutation of the ALK gene, apart from the EGFR gene. The level of PD-L1, which is another transmembrane protein, which acts as an inhibitor of T cells, helping cancer cells evade the immune system. The TNM staging, and the presence and location of metastasis. To compare the survival of these patients, I used some Kaplan-Meier survival curves, which we'll see in a moment. And the thing that I compared was the progression-free survival, which is the time spent from the beginning of the treatment, so from the first day when the patient first started chemotherapy with osimertinib, not chemotherapy, sorry, therapy with osimertinib, until either the patient died or the disease progressed. And if the disease progresses, in that case, the patient has to switch to another line of treatment. To compare these survivals, I used the log rank test in the Jamovi Online software. Out of my 79 patients, almost, more than half were censored, which means that they did not reach the event. They had not either died or their disease had not yet progressed. Most of my patients are still alive and going, and I'm still following them for now and in the future. So let's see. This is a Kaplan-Meier survival curve, which shows the general progression-free survival for all of the patients. Here below, we have the time in days. We can see that at 0 days, 100% of our patients are alive. And as time progresses, they start to either die or their cancer progresses. And by the time when we get to 3 years after they begin treatment, only about 25% are still alive. Now let's see how this survival curve changes depending on some specific groups. First of all, depending on the sex, there was no statistically significant difference found between the two sexes, so there's no difference between the survival of men and women, which is to be expected. Depending on the PD-L1 factor, on the PD-L1 level, there was also no statistically significant difference found. The P was over 0.05, although we would have expected patients with high PD-L1 levels to survive, to have a lower survival than patients with negative PD-L1 levels, because as I said, this PD-L1 helps the cancer evade the immune system. It was not the case in our study, and in fact, even just looking at the curves, we can see that actually patients with the PD-L1, with a positive PD-L1 had a slightly higher survival, but it was not statistically significant. Depending on the tumor size, on the T from the TNM staging system, there was a trend towards statistical significance, but the data here is a bit confounded by the very large number of subgroups. So if I had more patients, this might have been more conclusive. Depending on the lymph node invasion, there was no statistical significance, and again, I had quite a lot of subgroups here, so this didn't help either. Depending on the mutation exon, there was no difference found between the two big sites where the mutation usually happens in the EGFR gene. And depending on the metastasis site, most of the cancers metastasized either in the brain, in the liver, in the bone, in another lung, or in the pleura, or in another site. And comparing these 5 groups among each other, so each group compared to all of the others at the same time, there was no statistical significance, but there was a trend towards significance. And because I noticed that people with lung metastasis seem to have a lower survival, I compared their survival to the survival of everyone else combined. So just people with respiratory metastasis versus everybody else. And in this case, we can see that indeed there is a statistically significant difference between the survival of patients with respiratory metastasis, which have a lower survival than patients with any other type of metastasis. So in other words, having metastasis in the other lung or in the pleura lowers the survival of these patients. Now, my results are not really amazing because of the low sample size, just 79 patients, although maybe following them for a while more will help me get some more accurate data. If we look at the literature, we'll see that many other prognostic factors have been found and discussed, such as age, obviously, gender in some studies, the BMI. Actually, it's not what you'd expect. Patients with a higher BMI have a higher chance of surviving than patients with a lower BMI, because if they start off with a higher BMI, they have, well, more reserves to lose. The tumor size is, of course, implicated in the survival, as well as the cell differentiation, the smoking history of the patients, and the performance index when they begin treatment. But I did not have access to these data. As I mentioned at the beginning, the driver mutation, the presence of a driver mutation that we can identify is also crucial, because patients who do not have a driver mutation will have to stick with standard chemotherapy, which is not as efficient as targeted therapy. So having a driver mutation that we can identify with genetical tests help us pick a more targeted and a more efficient treatment for our patients. In conclusion, of course, I have to say this line, that further studies are necessary in this domain, studies with a greater amount of patients than my own. We should take into account that even in my small sample, the metastasis site greatly influences the prognosis. So not only the presence itself, but the site where the metastasis is important to the survival of these patients. And of course, nowadays in oncology, we cannot do anything if we do not test our patients for the mutations that their cancer cells have. If we go around trying to cure a tumor without knowing its genetic profile, it's like going to battle with your eyes closed. It's almost impossible now to properly treat your patients if you don't test for multiple genetic mutations. And lastly, the challenge that I met during my little study is that there is a lack of detailed, uniform, and explicit data in medicine. At least in oncology, it seems to be a recurring theme. And if you want to do any sort of research on patients, it's important that you either find or you try to create yourself a database which has clear data and complete data, because that's so rare to find. Thank you for listening to me, and if you've got any questions, I'll gladly take them. Thank you.
Next on stage is Popescu Aniela presenting antisynthetase syndrome, a rare but clinically significant autoimmune condition.
Good afternoon, everyone. Dear colleagues, my name is Daniela Popescu, and today I'd like to present to you an illustrative case of antisynthetase syndrome, which is a rare autoimmune disease with significant clinical implications. Now, what exactly is antisynthetase syndrome? It is characterized by the presence of it is characterized by the presence of antisynthetase antibodies, as we can see there, and various manifestations such as immune myositis, interstitial lung disease, arthritis, Raynaud's phenomenon, and skin lesions. Now today, I'd like to present to you the case of a 59-year-old woman who was admitted into the rheumatology department with symptoms like myalgia, proximal muscle weakness, inflammatory joint pain, Raynaud's phenomena, and exertional dyspnea. As we can see in figure number 1, doing physical examination, we found a heliotrope rash or dermatomyositis glasses. As we can see in figure number 2, she had the mechanic's hand on both the second finger, so bilateral. Also, the physical examination revealed her swollen hand joints and erythematous violaceous plaques on both her legs and on the back of our patient. We performed a high-resolution CT, and why is that important? Because antisynthetase syndrome is associated with a high risk of developing interstitial lung disease. As we can see here, our patient had the ground glass opacities in the posterior basal region, which is characteristic to the interstitial lung disease. Moving on to paraclinical investigation, we had elevated muscular enzymes. We also performed an electromyography, which revealed a myogenic pattern with acute muscle lysis. The biopsy showed immune myositis aspect, and the antibodies were anti-Jo1 positive. And the significance was pretty important. Spirometry came back normal, and the DLCO was decreased to 66%. The final diagnosis was idiopathic immune myopathy, interstitial lung disease, and antisynthetase syndrome. Now, when it comes to the treatment, we started as soon as we had the diagnosis with corticosteroid therapy and immunosuppression with classical immunosuppressants such as methotrexate and mycophenolate mofetil. And our patient responded really well to the therapy, but unfortunately, when we tried to reduce corticotherapy, she had an exacerbation of her symptoms. So we had to escalate the immunosuppression, and we elevated the doses. And we also put into perspective starting biological therapy with rituximab. Now, what is really important to remember from this case is that depending on which antibody we have, we can have anti-Jo1, such as our patient, or anti-PL7, PL12. There are different phenotypes of antisynthetase syndrome, each with its own prognosis and manifestations predominantly. Anti-Jo1 is the most common subtype, and it is highly associated with interstitial lung disease, as we saw here in the case of our patient. Early identification of the triad myositis, arthritis, and the mechanic's hand is very important for the diagnosis, and the high-resolution CT and the antisynthetase antibodies are mandatory tests. Management it must be individualized due to the very much variety and very heterogeneous character of this disease. We have to take into consideration maybe the most important aspect that the interstitial lung disease may progress. Thank you. This is my references and acknowledgements.
Now presenting is Paulina Antonio, who will present AI in infectious disease clinical practice, a talk that brings together tech, diagnosis, and the future of medicine.
Okay, so hi everyone, I'm Paulina. So now I'm going to present specifically on our article that was published, that is the Artificial Intelligence in Infectious Diseases, Clinical Practice, and Overview of Gaps, Opportunities, and Limitations. So a few information about the background on why this article was even basically published is that obviously infectious diseases remain a major issue currently happening throughout the world. What does that mean is that we do have global health issues going on, specifically going from the increase in antimicrobial resistance to diagnostic complexities to even the speed of outbreak that we currently have. For instance, COVID-19 was a major one. So yeah, obviously these are some of the challenges that do arise, and that's why we went into publishing specifically an article on how currently artificial intelligence is able to support and help us when it comes to giving innovative tools and diagnoses on how to surveillance as well diseases, and then of course on how to manage patients. So here's the structure and function of AI, but more specifically, what you need to understand is that we do have different types. So we do have the mechanical learning that is specifically able to recognize patterns on diseases and then of course use it in making decisions when it comes to our patients. Again, we do have also, as you can see, the deep learning that is about a more advanced way of AI that is able to analyze specifically large and unstructured databases and then use them, for example, imaging, genomics, or anything in that sort. And then we also do have the reinforcement learning that is more specifically about taking real-time learning and mimicking specifically human cognitive processes. So now we're going to go into key applications in infectious diseases. So obviously AI is currently a huge thing when it comes to diagnostics. So it is able to give decision support systems and then use them to make faster decisions when it comes to clinicians and also make more advanced and accurate diagnosis as well. So obviously we do have imaging analytics as well that is used through AI that is able to detect patterns of diseases and then of course use them in pathology and radiology too. Perfect. So then we also do have AI in able to assess outbreak manage and also in surveillance as well. So they're able to analyze those data and then predict when an outbreak is going to happen and again monitor epidemiological trends too. And then we also do have in specifically personalized medicine, that is an AI that is able to customize specifically treatment and strategies on how to treat a patient based on their profile, which is really individualized, obviously. And then, of course, improving their efficiency and the outcomes too. Again, we also do have a huge thing in drug and vaccine discovery. Again, it's able to help researchers being able to identify which compounds are able to be used more specifically into making those vaccines and into going into specifically more personalized treatment in each disease. And then we go into limitations and challenges. So obviously you can see a huge number of those. But yeah, a huge thing is privacy when it comes to data. And the reason is that specifically really sensitive medical information are being handled by AI. Again, as we proceed, we hopefully will be able to filter this in a way, but this is a huge still thing that is currently trying to be tackled when it comes to AI. Then also we do have biases, and that could be because of the algorithm in specific populations, and that can skew specific outcomes when it comes to specific people and marginalized populations. Then we do have issues with transparency, because obviously it's really difficult to get an AI and then process it well and then interpret all those models into specific information. And then we do have the ethical and regulatory issues. Again, I think it makes sense. There is not really any framework currently that is allowing AI to be used more specifically into making sure that we are using it safely. So that is also another issue. And then finally is the technical barriers, that is about the data scarcity, the spectrum bias, and then again, the need of large and high quality databases. These are a few of the things that currently are an issue when it comes to addressing AI into medicine. And then more specifically in conclusions, again, AI has a great potential on becoming a great tool when it comes to using it, to using it when it comes to treatment or also diagnosis. But unfortunately, we are suffering when it comes to the practical and ethical challenges. Again, if these are being improved, we can obviously have a specific tool when it comes to diagnostic, surveillance, personalized care of each patient. But those need to be addressed specifically by clinicians, data scientists, policymakers, and obviously patients being open to using AI into their lives and having that integration into their healthcare treatment. So thank you so much. You can also find the link specifically to the article that was published by me and my fellow students as well, and our professors, if you want to go into more details about it. But thank you so much. If you do have any questions.
Thank you very much, Paulina, for your presentation. So now we will move on to our break, where we will have our poster session, while also you will have the chance to have your lunch. And then we will gather up here again at 2 p.m. in order to conduct the rest of the presentations. So please, let's all meet outside at the hall. So thank you. So, hello everyone. Let's now continue with our second session. Thank you all for coming. So, now we will have a presentation on the theory of degeneration by Apollon Haralambous.
Okay. Can everyone hear me? Okay. I'll be presenting about the theory of degeneration and how it connects to the heredity of mental illness. I'll explain what that is in 1 second. This is a table of contents, it's unimportant. So, basically, we are in 1830s France. There's a cholera epidemic, and medicine is terrible at the time, so it can't really deal with it. It loses a lot of trust. It loses the trust of the people, and it doesn't really, it has to redefine itself in order to become a science again. So, there comes a French psychiatrist, a psychiatrist who believes that in order to reform society, which has come under very difficult conditions after the Industrial Revolution, where there's a lot of poverty, sickness, and it's overall terrible. So he believes that to reform society, we should use psychiatry together with philosophy and religion, specifically Christianity, in order to fix society. Basically, it's this guy, Benedict Augustin Morel. He articulates a concept of degeneration, and he sets the basis for a biological approach to psychiatry, which we still use today. Yeah, I said all that, I guess. Let's go into the theory itself. The term degeneration comes from the Latin genus and the prefix de. We see it as a term even as early as the 15th century in Latin and ancient Greek texts, and not ancient, Greek texts, to describe a degradation of the species. Morel's basic principle is that the degradation of the human species, in addition to endogenous biological factors, is also the result of exogenous ones, such as society and the conditions of living. His goal was to classify all mental illnesses based on their cause and create a nosological framework. He believed he could do this by looking at the outward appearance as well as behaviors. He published the theory of degeneration in 1857. It was the first actual attempt to interpret insanity, mental disorders, and criminality, and connect it to heredity. He set the basis for the further development of psychiatry as a science. We see here what he believed to be degenerates, which is a term that has been used widely since then to describe many things, especially medical ones, but also societal. He believes, he thinks these people had parents of low intelligence, and he judges this by the abnormal head measurements. We also see ear deformities and a narrow width of the chest. These are some signs of their deviation from the normal human type. So let's see what he considered to be causes of degeneration. Basically, he had a very serious problem with alcoholism. He believed that it was one of the main causes of degeneration, and he believed that it had a hereditary factor. It's important to note that he didn't think all children of alcoholics would be alcoholics. He found a predisposition, which is a concept that we still have in genetics today. The causes of degeneration, he believed, were due to depravity, violation of hygiene rules, use of drugs, which caused serious perversions to the functions of the nervous system, And he also mentioned as causes the condition of the soil, which could be could have poisonous substances, famines, epidemics, and the quality of air and food. So we see that he considered causes of degeneration to be poverty, hygiene, famine. We see that he believed degeneration to be a problem of the class of workers and of the impoverished. Here we see children of alcoholics who had growth failure and lack of reproductive capacity. These are all drawings by Morel in his treatise. His conclusions, after being spending a lot of his years in asylums and looking at the histories and reasons that people were incarcerated in asylums, he found, especially considering alcoholism, that in the first generation we find immorality, depravity, and excessive alcohol consumption. In the second, we have tendency to alcoholism, as we said. In the third, we find hypochondriac tendencies, melancholy, and suicidal tendencies. And in the fourth generation, the genus would stop. We would find lack of reproductive capacity. He believed there were some very important ways to reform the human species and bring it back to what he thought was the perfect archetype of man, as God created him in his image. He thought to improve living conditions through education, treat all agents of intoxication through the medical art, intoxication being either through alcohol or various substances, apply the moral law, which he really believed was something objective, which starts with the family and then with the moralization of the whole society. He also believed that as a society, we should marginalize deviants and modify the conditions which are responsible for the differentiation of humans. Let's see how the theory was received. Psychiatrists at the time really needed a way for their profession to have some value, because medicine as a whole was under fire, but especially psychiatry was at its early beginnings. So the asylum reformists at the time were very quick to adopt the concept of heredity, and of heredity of both mental disorders and the resulting cases, which was criminality. They believed that criminality was a result of mental disorder. In the mid-1800s, after he publishes a theory, he argued that mental illness worsens across generations, leading to sterility or extinction. He coined many terms which would be later used by psychiatrists for many, many years. Basically, the theory was a way to find actual evidence in a science where there wasn't really organic lesions to look at, there weren't brain lesions to look at and determine what was problematic with a patient. He tried to create a nosological framework in order to classify mental illness and combat it in order to create a better society. This is very interesting for many reasons, because first of all, we still use the concept of heredity today. Genetics really occupies itself with the heredity of mental illness and the biological factors behind it, and this begins with Morel's work and theories. But it also had another side, which was discrimination and classification of people through their outward appearance or behavior. This would lead in 1883 to the creation of eugenics by another French psychiatrist. It was supposed to study the factors that could be controlled in order to make the human race a better species and a better society. But it will lead to classifying everyone who deviated from the dominant aesthetic standards as a degenerate, and for the outcasting, marginalization, and even genocide, as we saw in Nazi Germany's Final Solution. After the war, since this theory was used to justify the atrocities that took place, we find a big aversion to this theory, and it was never really disproven in a way, but abandoned by the scientific world. But it had a significant impact on both medical, on both medicine at the time and today, but also to society. It influenced social policy and created a scientific framework which could be used to oppress and marginalize whoever wasn't good for authority. To conclude, most of these factors that Morel found are still important today, and genetics still studies those factors. It has a lasting impact on both society and genetics, and the factors he found are very significant in determining the future of psychiatry and of social policy today. Thank you.
So thank you very much, Apollo, for your presentation. Now to the world of regenerative medicine with a very interesting topic on the rise of brain organoids. We want to give a warm welcome to the podium, Anastasios Villas.
Hello everyone. Today I'm Anastasios Villas. Today I will be talking to you about brain organoids and their applications to medicine. So let's start with the basics. What are brain organoids? The definition is a miniature lab-grown brain-like structure derived from stem cells. They have specific key features like they contain neurons and glial cells, they are able to mimic early human brain development, and they can be simply grown by a simple skin sample. Now, why do we need brain organoids? Well, for starters, in brain research, the brain is very inaccessible, both in physiological terms and ethical terms. So, in order to understand better the advantages of brain organoids when it comes to disease modeling and drug testing, we need to examine better the tools that we have in research as we speak now. So, for starters, we have rats, we have animals where we use them, but the issue with them is that they are not human. They do not share the same physiology. They do not share the same genome as us, which leads to a lot of inaccuracies when it comes to drug testing. Then we have autopsies. Having an autopsy and having a dead brain doesn't really help you understand the development and how brain functions. You can see the result of the development of the brain, but you cannot really tell a lot apart from anatomy, of course. And then we have for body on a chip. For those that are not aware of what a body on a chip is a simple chip where basically it has a layer of cells from a lot of different organs. This specific one from Cornell University basically has 10 different organs with a simple layer of cells from a lot of different organs where you can test it. But the issue with this is that it lacks the complex three-dimensional structure that a normal organ has. This is just a simple 2D cell culture. Now, how do we make brain organoids? As mentioned, we simply take a simple skin sample and then we begin. We have the stem cell generation. We convert the skin cells into iPSCs. Then we begin the neural induction, which we culture basically these cells, and then we using growth factors, we begin making the neural tissue. And after that, the 3D growth comes in, where basically we use a gel matrix along with bioreactors in order to mimic the brain's development. Now this secret formula, which is basically the use of different nutrients and different proteins in different conditions, which makes stem cells differentiate into brain cells. It was discovered like in 2013. It has been over a decade since we have learned how to make stem cells into brain tissues. So scientists back then could have imagined that in the future we would be using these brain organoids in order to do whatever we please with them, like modeling diseases or drug testing. So now let's talk about the advantages of brain organoids. Apart from their 3D complex structure that we mentioned earlier, it is really important in personalized medicine because we are using the cells from a patient. You are taking your patient's brain and you are producing a smaller version of it and you're putting it on your dish in front of you where you can test drugs on it, you can see how their disease developed and how the malfunctioning brain developed. And we will be talking about this, especially for Timothy syndrome in a case study. Now, the big question, is this ethical? Because at the end of the day, you do have a brain in front of you. Is this brain conscious? Can it think? Well, we can say with not certainty, but with the facts that we have of today, that no, these brain organoids cannot think and they do not have a consciousness. But why not? Well, first off, we have the size. Brain organoid, at least one of considerate size, it has around 100,000 neurons, while normal human brain has 86 billion. But then again, you're going to ask me, Anastasis, they're like animals, like the common fly that has 160,000 neurons, and it functions normally. It eats, it reproduces, it lives, it breathes. But here comes the second piece of evidence, which is the disorganized structure of the brain organoid. Think brain organoids as a computer. You have a computer with the different parts inside of it. You have RAM memory, you have the CPU, you have the processor, you have the motherboard, right? Take all of these parts of the computer and wire them randomly and chaotically. If you try to turn on that computer, will it work? No. The exact same thing is happening with brain organoids. You can test and study specific parts of them, but as a whole, it cannot function as an actual brain. Now, let's start with the case studies. The first one, really interesting, by Stanford University. Their goal was to test if human brain organoids can integrate themselves within rat brains. Basically, how did they do this? They transplanted a brain organoid into a newborn rat. I think it was 2 to 3 days old. Then they used optogenetics to stimulate human neurons. Basically, they had a water reward or no reward system using blue and red lights. And they would check the brain, that specific part of the brain that the brain organoid had integrated itself and had expanded and connected itself with a normal rat's brain, to see if there is brain activity, if there is neurons, if there is synapses. And there were. So right now what you are seeing in that picture over there, is that outlined part of the rat's brain. What you are looking at is the first successful partial brain transplant. So you can see where the implications of this can go. We're talking about literal brain transplants here. Now, next up, we have in disease modeling, we have the modeling of Timothy syndrome, which is a disease caused by a genetic mutation, which causes epilepsy and autism. Now, what did these scientists do? They basically took a skin sample from a patient which had Timothy syndrome. Once that was done, they created a brain organoid which therefore had Timothy syndrome. So then they started doing an ASO therapy to correct RNA splicing errors. Basically, they found how the pathological protein was made, and they produced drugs that can stop the pathological protein from being completed and made into the protein that causes the pathology. Now, beyond medicine. Now we're going to really interesting territory. I had to mention this, even though it's not medicine, but okay. Biocomputing. Back in 2024, when I first started creating this article, which this presentation is based on, I saw a startup Swiss company called the Final Spark, and they had made Neuro Platform. The Neuro Platform, that is the bottom picture, What you're seeing at is the first processor using brain matter in order to function. And what you're looking above is the first commercially available biocomputer that exists and that came out a few weeks ago. So what does this open to? It opens the horizon into a new classification of computing, where right now we have binary, digital, we have quantum lately, but now we are delving into biocomputing, making bio-AI, which will be a more adaptive form of AI, and at the same time it will be extremely energy sufficient and economic. Now, to conclude, let's talk about a bit of the future of the brain organoids and what do they promise. So, a small funny thing, to be honest, is that as quickly as brain organoid research is developing, so are the brain cells, so are the brain organoids themselves. For example, one time they found out that once you develop the brain organoid, they start developing eyes, their own eyes, optic cups, that they are actually light sensitive. But then, now, let's talk about what they are also trying to do. They're trying to better vascularize these brain organoids, because if brain vascularization is a really important thing when it comes to their size, because the bigger they are, the more drug testing you can do. But at the same time, we are delving back into the ethical dilemma. If they grow, do we suspect that they might start thinking? So right now, we are both trying to delve into this balance between physiology and ethics regarding the brain organoids. So our closing thoughts are that the organoids are able to bridge gaps between lab research and clinical applications, as well as science fiction. So this is the article. I made it in Edge of Medicine. This is the QR code if you ever want to find out. You can find it on Instagram as well. So thank you all so much. Do you have any questions? Yes, of course.
So when you say there's no evidence of consciousness, whatever,
yes.
How would you quantify or how would you test, like, point on for consciousness?
Like, what would you consider? Like, how do I know that this thing is not thinking?
I mean, when you say that there's no point of consciousness, how do you quantify it medically from a statistical point of view?
That is, there is a guideline for this called Current Consensus, which was in 2024, where basically they analyze these brain organoids in order to understand how exactly do their brains work, how exactly like the brain activity, of what nature is it. And as I said, they are so severely deorganized that they cannot function as a brain. Like physiologically, both as a structure, it doesn't work. And both at the same time, scientists with these guidelines manage to, be able to say, no, this thing, at least with the data we have now. But then again, it's still up to debate. Like, scientists are not sure about this. There still are, it is pretty complicated. Any other questions, people? Okay.
So thank you, Anastasia, with your amazing presentation. Now moving on to the small world of microbiology, or may I say virology, with a topic about a virus that has been troubling children a lot and also adults, with the respiratory syncytial virus. Please welcome to the podium Maria Muka. Where is she? Ah, there you are. I was expecting you this way. You can step. There you go. Let me put in full screen. You're good to go.
So hi guys, my name is Maria and I'm a third year medical student, and today I'll present a comprehensive overview on respiratory syncytial virus, also known as RSV. So this is our table of contents. So what is RSV? So it's a human respiratory pathogen that causes acute lower respiratory tract infection, which leads to bronchitis and pneumonia. It was first discovered in chimpanzees in 1955 when they had respiratory diseases. Then in 1957, it was isolated from babies with severe lower respiratory tract infections. Usually, this virus occurs in healthy infants. However, in conditions such as premature birth, cardiopulmonary diseases, lack of initial infection, and absence or limited levels of maternal antibodies responsible for the protection against RSV can increase the risk of susceptibility to this virus. So usually symptoms are like a cold flu symptom, which can range from mild to severe. So in mild infants, symptoms can go from fever, coughing, changes in the breathing patterns, fussiness, and decreased appetite. In severe symptoms or severe cases, it could be noisy breathing, wheezing, flaring of nostrils, short or fast breathing, as well as pauses while breathing. In children, it's a bit not as infants, so it's fever, cough, runny nose, difficulty eating and swallowing, as well breathing, which is breathing slower than normal. So genomic composition. So RSV is a negative single-stranded RNA enveloped virus that is 15.2 kb in lengthwise. It is a member of the genus Pneumovirus and comes from the family Paramyxoviridae family. So I'm sorry for my pronunciation. So it is composed of 10 genes that have 11 proteins. 2 of these proteins are non-structural, NS1 and NS2. So NS1 functions by inhibiting the type 1 interferon response, suppressing dendritic cell maturation, and reducing inflammatory response activation. NS2 functions by preventing ubiquination of inactive RIG1 and MDA5, as well as blocking the type 1 interferon signaling by binding to host molecules. So RSV could be filamentous or spherical enveloped virion, and it has 3 key glycoproteins, which are the G protein, the attachment protein, F protein, which is the fusion protein, as well as the SH protein. So the G protein will allow the attachment of the viral envelope through 2 mechanisms. It can either be by membrane bound, so viral attachment of the viral envelope to the host cell, or by secreted isoform, so basically by like hiding from the immune system, if we can put it that way. And we have the F protein, which will help fuse the viral envelope within the host cell membrane, as well as the SH protein, which is a pentameric ion channel that is believed to delay apoptosis of the virus. So RSV is into 2 subgroups, so RSV-A and RSV-B. A has 23 genotypes, B has 6 genotypes, and the classification will be based on antigenic reactivity. So basically, the protein that will allow RSV to be replicated into the ciliated cells, therefore increasing likelihood of reinfection, as well as genetic variation in the G proteins. So we also have internal components, so the viral matrix protein, M protein, which will support the virion structure. We have the nucleopeptide protein, the phosphoprotein, and the L protein, which will preserve the genome, therefore it will support the replication of the virus, as well as the M21 protein, which aids in transcription in the transcription process. So RSV can be transmitted through large respiratory droplets. It could be either through the eye or the eyes or nose. Okay, it lasts for 2 to 8 days, and it has different timing on other surfaces. So if it's on hard surfaces, it can last up to 6 hours. Skin, 20 minutes, rubber gloves, 90 minutes. This is why it's important to follow the guides in hospitals, usually. Now, the primary infection site for RSV is in the epithelial cells at the lower respiratory tract infection. RSV will actually replicate in the ciliated cells. This is where we will start being able to target, to find the targeting cells as well, because it will target the type 1 pneumocytes, intraepithelial dendritic cells, as well as basal cells. And the airway obstruction will occur by the epithelial cell shedding, mucus accumulation, as well as buildup of luminal and intraluminal cells. Now, for diagnosing, there are 2 simple ways. So it's like a PCR test. So first of all, we have the lateral flow immunoassay. It's a nasopharyngeal swab. You put it on the strip. This strip will detect the F protein antigen, so it will go through antigen-antibody binding. The strip will change color. You will detect it. It takes 15 minutes. It's quick and easy. You also have the RT-PCR, also known as reverse transcription PCR, again, a nasopharyngeal swab or aspirate. You put it on the strip. It will detect the RSV RNA. So RNA will be transformed into cDNA, so allowing PCR amplification. It takes around 20 to 30 minutes. And the good thing about this test is you can detect if it's RSV-A or RSV-B, as well as quantify viral load. Now, throughout the years, we needed to try to develop a new vaccine, because it is a deathly virus after all. So in 1966, there was the FIRSV vaccine, which was the first one. It constitutes of a formalin inactivated virus that was tested on animals than infants. However, it did not meet expectations as it was ineffective, and rather than regressing the disease, it enhanced it. And there was a study that revealed that it caused 2 infants' death. So it was discontinued. This is why we created the live attenuated vaccine, which weakened the live virus but does not worsen the disease post-exposure. However, they did have concerns about the genetic stability and the unwanted mutations under selective pressure. There was also the chimeric vaccine, which was engineered from multiple viruses to elicit T-cell response. It was effective in animals, but it was not safe for immunocompromised patients that had the BCG vaccine. And there was the subunit vaccine also, which is a single protein or peptide such as the F protein that triggers the immune memory. At high doses, it was safe, but at low doses, rather than also like decreasing risk of disease, it actually enhanced the disease. Now, the only antiviral treatment that was FDA approved was ribavirin. So ribavirin basically will suppress the replication of DNA into RNA of the virus through 2 mechanisms. It could be either through direct mechanism, so there will be RNA capping interferences and lethal mutagenesis, or by indirect mechanisms, so through the IMP inhibition or immunomodulatory effects. Usually this drug can be administered in 3 ways. It could either be in IV, so 7 days, oral 7 to 10 days, or aerosolized. But as every drug, there are side effects. So side effects can range from chest pain, rashes, to bronchospasm and vomiting. However, the use is limited due to cost as well as risk, specifically in immunocompromised patients. Now, I also like to include this study about reinfection rates of RSV. So this study was conducted in the US, and it had more than 6 million children that were less than 4-year-old. And results showed that if children got infected within the season of RSV, the risk of getting reinfected is the same. Highest reinfection rates were at the age of less than 1. Reinfection with age increases, but there was a slight increase at the age of 4. And annual reinfection rate turned out to be higher than seasonal type lines. So in conclusion, RSV is a negative single-stranded RNA with an envelope and the leading cause of hospitalization of children that are less than 1-year-old. It includes the G, F, SH, and M protein, which are crucial for viral entry and structure. The transmission, as I mentioned, respiratory droplets through the nose and eyes. It has no approved vaccine yet, but there is the only FDA-approved antiviral ribavirin. Thank you so much. These are my references. Tell me.
You mentioned that RSV vaccine will be not effective in people that have received the
BCG. It was one of the vaccines.
Why does it happen?
I didn't go into details much about it, but people that got the BCG vaccine before, it reacts with something within it.
Okay, so it's a reaction.
Yeah, it's a reaction that doesn't help. But there is actually a vaccine. It's called Apivlex. This is a new vaccine, but it's not for children. It's for adults that are more than 60 years old. This is a new vaccine.
Thank you.
Thank you.
So, let's move on. Now, welcome to the podium, Andreas Hadjiovangelou with an interesting topic in public health. So, please come join me. Okay. And, good luck.
It's on. And I continue like this, right? So, hello everyone. My name is Andreas Hadjiovangelou, and I'm a second-year medical student here at the European University Cyprus. It's a great pleasure to be here today to speak to you about a critical milestone in public health history: the chlorination of water and the pivotal role played by Dr. John Lill. Thank you for joining me in advance. So, everyone has a hero, an individual they admire and strive to emulate. For a young aspiring footballer, that hero might be Lionel Messi. For a budding musician, it could be Beethoven. As someone pursuing future in medicine, my inspiration is Dr. John Lill. You may not be familiar with his name yet, but by the end of this presentation, I hope you'll understand why he has had such a profound impact on me. Perhaps he might even become a source of inspiration for you as well. So, the COVID pandemic of 2019 initially caused widespread negative reactions from the public, but it ultimately imparted critical lessons that humanity had long needed to learn. The empty shelves of antiseptics in supermarkets and pharmacies underscored the importance of a simple yet vital invention of the modern civilization. A humble chemical compound that not only enhanced public health and increased life expectancy, but also played a pivotal role in the sexual revolution and the advent of bikinis. Remarkably, these seemingly desperate elements are somehow interconnected, so stay tuned. To those who believe that public health was in crisis during the COVID pandemic, it is crucial to consider the conditions of the early 20th century metropolises, such as New York City, London, and Paris. These cities were basically huge favelas, were rife with diseases. Streets were littered literally with horse excrement. Cemeteries were overcrowded with decomposing bodies, and butchers sold meat in unsanitary conditions, creating breeding grounds for bacteria and viruses. Even if a heavy rain, while temporarily cleansing the streets, led to effluent mixing with the drinking water, thereby triggering successive pandemics. So you have smallpox, tetanus, typhus, dysentery, cholera, and yellow fever. They were rampant. Consequently, the average life expectancy stagnated at 40 years, as you can see on the chart. So the turning point arrived with Dr. John Snow's discovery that contaminated drinking water was a primary source of these pandemics. This revelation prompted efforts to decontaminate public drinking water, but now scientists and medical professionals came across the first major challenge. From what exactly is water supposed to be decontaminated from? Remember, at that time, nobody knew about bacteria, viruses, protozoa, and other pathogens. So, with the advent of high-quality microscopes by Zeiss Optical in the 1870s, it enables pioneers like Robert Koch and Louis Pasteur to discover bacteria and develop methods to culture them, thus giving rise to the germ theory of disease. Robert Koch subsequently invented a reliable method to test drinking water for bacterial colonies. So a question for you. Before these advancements now, have you got any idea how they tested drinking water back in the day? Through consumption. They drank it. And if they were alive after that, then it was deemed safe. That was 100 years ago, happening in Cyprus as well. So, and now we come across the second major challenge. How? How exactly do you kill such an organism? You basically have an animal that you cannot see with the naked eye. It hunts in packs of trillion members, and you cannot kill its nest because its nest might be a glass of water, your body, or even the entire water treatment. So how on earth do you kill such an organism? So the solution emerged in 1908, thanks to Dr. John Lill, a local physician in New Jersey, and the hero of today's presentation. Lill was driven by personal tragedy because his father had succumbed to dysentery during the American Civil War. Just to put you in context, at the battalion at which his father served, 197 soldiers were killed. 19 of them died from a bullet, whereas the rest of them, 178, died from infections. So Lill embarked on a quest to find an effective decontamination method. Lill's experiments led him to conclude that pathogens could be eradicated by using a chemical compound that disrupted their protein structures, calcium hypochlorite, commonly known as chlorine. So chlorine is already in use as a household disinfectant, but it was met with skepticism and concern due to its odor, eye irritation, and toxicity. 2 to 3 glasses of chlorine could kill a human successfully. Nevertheless, Lille was convinced that in the correct concentration, chlorine could safely decontaminate water. Despite initial resistance from the scientific community, Lille conducted a bold experiment in 1908, and this act is the whole reason that I'm here today to share his story with you. He clandestinely introduced gallons of toxic chlorine into the main water tank in New Jersey that supplied 200,000 people. 3 days later, he was arrested with charges of terrorism. However, Lille defended his actions. However, Lille defended his actions, asserting that New Jersey now had the safest drinking water in the world. And this is a famous dialogue from the court back in the day. Subsequent data supported his claim as child mortality rates halved within a few years. This table shows the death rate for typhoid fever among children in that age. Keep in mind that at that time, the death of a child was a common occurrence. It is something that people expect to happen. The actions taken by Lille undoubtedly raise significant ethical dilemmas. In contemporary society, such authoritarian measures would be deemed unacceptable. However, Lille was a product of his time, and the urgent need for public health reform necessitated decisive action. Desperate times called for desperate measures. Lille's contributions extend far beyond the decontamination of water. By the early 50s, the widespread adoption of chlorinated water facilitated the development of public swimming pools, enabling an entire generation to learn how to swim. These pools quickly became social hubs for young people, influencing cultural norms, including the evolution of swimwear bikinis, and ultimately contributing to the broader societal shifts that culminated in the sexual revolution of the 70s. This serves as a prime example of how a simple scientific breakthrough can catalyze a cascade of innovations, shaping both scientific progress and social change. In conclusion, I firmly believe that aspiring physicians, myself included, must extend our engagement beyond the prescribed curriculum. Mastering the fundamental content is merely the first step. It is equally imperative that we acknowledge and appreciate pioneering scientists whose dedication and sacrifices had laid the foundation for modern medical advancement. By understanding the historical trajectory of scientific progress, we not only honor their contributions, but also cultivate a deeper appreciation for the knowledge we have today. Thank you for your attention. Any questions? Thank you very much.
So yeah, sometimes public health can make medical students skeptical, but it's a part of our everyday life. So let us begin for a moment. Nearly to the end, falling into a world that is also very familiar to me, using natural extracts. And we can welcome to the podium Popescu Aniela with her topic of, sorry, that was a mistake. Iova Olga Maria, my mistake, forgive me about that, about Anthelis vulneraria extract in wound healing. Yeah, please join me. Iova, you can join me. Forgive me for my mistake. Good luck.
So, hello everyone. My name is Olga Iova. I'm a fifth-year medical student from the University of Medicine and Pharmacy, Iuliu Hațegaну, Cluj-Napoca, Romania. And today I want to talk to you about a study we made concerning the healing effects of Anthelis vulneraria in a wound animal model. We did this study because in today's day and age, there are more and more patients with chronic wounds, and of course the need for therapies is also rising, and many have turned their attention to alternative let's say, I'm sorry, plant therapies, and that's exactly what we did. We chose this plant, Antilles vulneraria, which is a traditionally used medical plant, which has been shown in previous in vitro studies to possess high quantities of polyphenols. And as I'm sure all of you know, polyphenols are substances which help in all sorts of medical afflictions, including healing. So what did we test? We used this extract from the plant on a burn model, and we quantified our results by macroscopic, macroscopic, and biochemical testing. And we also wanted to replicate past literature findings by analyzing the exact polyphenol composition of the plant. What we found out in the end is that this plant does indeed possess in vivo healing effects, most likely due to its high levels of polyphenols. So for the animal experiment, we used 32 rats, which were divided into 4 groups. Negative control, which was treated with a base cream. Positive control, treated with a skin healing pharmacy cream. And experimental group 1 and 2, which were treated with Antilles vulneraria extract cream of 1, respectively 2 milligrams of polyphenols per centimeter square. We also collected skin and blood samples in order to assess, firstly, microscopic changes, and also to analyze the quantities of a bunch of enzymes, which are, I did not remember their names. So reduced glutathione, superoxide dismutase, glutathione peroxidase, and catalase. These are antioxidant enzymes, and oxidized glutathione and malondialdehyde, which are indicators of oxidative stress marker. I'm sorry, indicators of oxidative stress, and they are markers. Good. So we created a wound on the back of each rat on day 0, as you can see in the pictures. The wound was treated daily with the respective topical cream and was photographed on days 3, 5, 7, 10, and 14. On day 7, half of the rats were killed in order to collect blood and skin samples, the rest being killed on day 14. For the statistical analysis, we compared the healed area quantification, which was calculated by deducting the actual area of the wound from the specific day from the initial wound area, and we did this in order to correct for any, let's say, differences in the initial area of the wound between the rats. So the first picture is the typical aspect on day 0, and the second one is from day 7. I did not put any more pictures, and especially not from day 14, because on day 14 almost all the rats were almost healed. For the plant extract, we use a method from literature. We used the leaves. We wanted to use the flowers, but this plant only flowers in the second year. We did not know that. We didn't have any more time, so we needed to adapt, and we used the leaves. And the extract which we obtained was used firstly to create the 2 experimental group creams, and secondly to run a liquid chromatography analysis in order to assess the polyphenolic composition of the plant extract. You understand the meaning behind it. Okay, now moving on to results. What we did find out is that the experimental groups healed faster, so they had a higher healed area on days 5 and 7. And remember, we photographed them on days 3, 5, 7, 10, and 14, but we saw statistical significance only on days 5 and 7. On day 5, both experimental groups healed faster than the positive and negative control. On day 7, however, only experimental group 1, so the one with 1 milligram of polyphenols, actually healed faster and better than the positive and negative control. Moving on to the antioxidant metabolic profile. For the antioxidant enzymes which we tested, except for catalase, all of them showed higher levels in the skin samples in the experimental groups compared to the negative control. And for the oxidative stress markers, the levels were lower in the experimental groups when compared to the negative control. So this points to a general environment of antioxidant, so high antioxidant enzymes and low oxidative stress markers, which actually is very good for wound healing. For the polyphenolic analysis, here you can see the UV chromatogram. Please do not ask me to explain it to you. I really don't know what, what actually it means, but the spikes usually represent the polyphenols which could have been identified, and here you have the list of them, both the ones which could be quantified and the ones who could not. I will touch very shortly and say that all of these polyphenols have been shown in previous in vivo and in vitro studies to possess firstly and most importantly antioxidant properties as well as antibacterial and pro-healing, but I will talk more about this in the discussions. And for the discussions, the first question that may pop into your mind is just why just the 5th and the 7th day? Why not all of the days? And what actually influenced this? Was it the antioxidant metabolic profile? Was it the polyphenolic component which we found in the plant? And because nothing is perfect, I will also touch a little bit on the limitations of our study. Okay, in order to understand why we saw results only on day 7, on day 5 and day 7, we need to understand the pathophysiology of wound healing. And wound healing is mainly composed of 3 phases, and each phase is important and must be carried out properly in order to avoid acute or chronic complications. First, the inflammatory phase, then the proliferative phase, and lastly, the remodeling phase. For the inflammatory phase, as the name suggests, so of course there's the blood clot formation, but there's also a bunch of inflammatory cells which come and secrete a bunch of pro-inflammatory substances, which lead to vasodilation, secretion of nitric oxygen, and so on. This usually lasts for the first, let's say, 5 to 7 days after the wound creation. This is followed by the proliferative phase, in which basically there's a formation of new blood vessels and the deposition of collagen starts. And finally, the remodeling phase, the longer, which can last up to years in some cases. Here, the useless blood vessels are removed, and collagen type 3 is changed for collagen type 1, which is much more resistant. So, the days when we saw our results mainly overlap with the inflammatory phase, a little bit with the proliferative one, but mostly with the inflammatory. So, I think it's safe to say that we can assume that our extract worked by influencing the inflammatory phase. And this is a good thing, and we need to talk a little bit more about the inflammatory phase, because as I'm sure you know, inflammation is not a bad thing, it's a good thing, as long as the magnitude of the inflammation is all right. So too much inflammation, bad. Too little inflammation, again, bad. So what we believe that happened is that the extract helped in a way temper the oxidative processes that happened in the inflammation, and that's actually helped speed up the healing process. And this could have been created firstly by the, as I said, high antioxidant enzymes and low stress markers, but also because of the high quantities of polyphenolics, from our extract, which, as I said, possess very powerful antioxidant properties. So yes, we believe this is a pretty good pathophysiological explanation. Of course, there are many more things to be studied, but because our study was a pilot one, we are pretty pleased with our results. Okay, and for limitations, yes, small sample size, 8 rats, it's not enough, and it was never meant to be enough. It's just a, let's say, trendsetter study, what we did. The reduction of the sample size, there we basically kind of shot ourselves in the leg, because for the last week, we only got 8 rats per group. Maybe we didn't see results past day 7 also because we only got 4 rats. We did the reduction because we really wanted to see if there was any microscopic change, and we didn't find any microscopic change on both day 7 or day 14, so yay. Why we did not find any histopathological findings? So again, maybe the small sample size, maybe we did not use, let's say, advanced techniques. We used just hematoxylin eosin, sorry. And of course, we had results for the biochemical tests, but we could have done more advanced, but then again, there's a problem of budget. So, to leave you with the final conclusion, we believe our study could be a stepping stone for bigger, better studies which could actually help create new therapies for chronic wound patients. But overall, we were able to demonstrate that this plant, Antilis vulneraria, possesses antioxidant in vivo capacities, possesses in vivo healing capacities for skin wounds, and we hope that hopefully after we publish this article, we will inspire future groups of scientists to carry on with our work and actually implement this plant and create therapies for the patients who so much need them. Yes, these are my references, and thank you for your attention. And I think the presenter left, right? So you're also presenters. Okay.
Please welcome Peter Albert, presenting haloposaco dermatitis or reactive arthritis, a diagnostic mystery that reminds us how nuanced clinical reasoning can be.
Good afternoon, everyone. My name is Albert Petre, and today I will be presenting a case of hallopose ectodermatitis. Hallopose ectodermatitis, for those who don't know, you probably don't know because it's a very rare disease, is a subtype of pustular psoriasis. It belongs to the group of seronegative spondyloarthritis. I will go into more detail, but first I want. Sorry? Oh, is it better now? Okay, awesome. So first of all, I wanted to tell you why I wanted to present this specific case. First of all, it's a very rare disease, and it can be a useful differential diagnosis in many specialties, such as rheumatology and dermatology. And also to the fact that it presents a very specific interleukin pattern, and therefore it requires a very specific treatment, and it can be often misdiagnosed. And let's dive into it. So, first of all, what are seronegative spondyloarthropathies? I wanted to give you a quick rundown and give you some relevant examples to this case. So they are a group of 5 pathological entities. We will see them shortly, and they are united by a group of common symptoms. Mostly, they have chronic arthritic pattern involving the vertebral column. So they usually manifest with spondylitis and with sacroiliitis. And also, they usually present with oligoarthritis of the larger joints, such as knee or shoulder, but they can also present a polyarthritic pattern. And they have common lab findings, specifically the HLA-B27 antigen. Systemic manifestations are also very common in this group of diseases, namely manifestations like iridocyclitis and ulcers in the oral mucosa. And here are the 5 seronegative spondyloarthropathies I was talking about, but I will be focusing on just a few of them for this specific case because we will need them for differential diagnoses. First of all, reactive arthritis. Reactive arthritis is a self-limiting spondyloarthropathy that happens after a 1 to 4 week incubation period after an infection of the gastrointestinal tract or the urinary tract. And it usually manifests with oligoarthritis and as also sacroiliitis, but is a mild sacroiliitis that usually goes into remission after the disease is over. Dactylitis, so swollen fingers and swollen red painful fingers, and enthesitis, usually a pain that happens, so it's a pain of the insertion of the tendons, usually in the insertion of the Achilles tendon. And it also presents extraarticular symptoms, the ones I mentioned before. Psoriatic arthritis, also reactive arthritis doesn't really need a therapy. This is important because it's a differential diagnosis for what it will present, and it only needs adjuvant therapy, so like NSAIDs, but nothing else. Psoriatic arthritis, on the other hand, can be much more serious. It can only require adjuvant therapy, or it can even require biological agents, depending on the severity. It's also a spondyloarthropathy. It usually manifests with polyarthritis, in this case, of the small joints of the hand and feet. And the most obvious clinical manifestation are erythematous cutaneous lesions, which we will see in the case report also.
And there are multiple variants, one of which I'm presenting today, haloposa acrodermatitis, and nail involvement is very common. So also the cutaneous lesions are cutaneous squamate, so very dry skin that usually peels off. You will see them again. So these are the main the classifications of psoriasis. As you can see, acrodermatitis continua of Halope is a form of postural psoriasis that is localized. It is localized. It only happens in the hands and feet. And yeah, so haloposa acrodermatitis. As I said, it's a subtype of a subtype form of psoriasis. It usually appears after minor trauma. Minor trauma usually occurring in the one of the fingers, either feet or hands. But minor trauma can also be absent. It's not necessary. Suppurative nail involvement is always there. So if there's no nail involvement, we will usually be thinking of another disease. Also, the pathognomonic clinical manifestation are painful progressing skin lesions that are soft, aseptical pustulae that usually start in the fingers and progress proximally, but they do not go past the hands or feet. If they do, then that is a different type of spondyloarthropathy called the palmoplantar psoriasis. So, yeah. This is, I will not go into detail if this is the main, these are the main physiopathological aspects of these two diseases, psoriasis and the generalized pustular psoriasis. And what I wanted to emphasize here is that although, so spondyloarthropathies do not have clear clinical criteria, they have classification criteria. So although they are different clinical entities, they are very related. And although the interleukin patterns are very related to one another, they are more dominant for one disease. For example, for the interleukin 1 and 36 are for generalized pustular psoriasis, and therefore the treatment is very different. So that's why we have to correctly classify and then treat the diseases. So onto the case report. We have a 37-year-old male patient that presents with painful skin and nail lesions on both hands and feet. We'll see them shortly. Lower back pain, polyarthritis, specifically in the left knee, the metacarpophalangeal joints, the proximal interphalangeal joints, and this arthritis has an asymmetrical pattern. And also the inability to walk or stand unsupported. That happened only when the lesions progressed. So upon body examination, we can find painful pustular erythematous exanthema on both hands and feet. The lesions are limited distally and are bilateral, as I said. Psoriasis like squamate, onychodystrophy, and hand and joint arthrosis. We'll see them shortly. And the swollen left knee. I actually forgot to include the swollen left knee. It's in my poster if you want to see it. It's just a swollen left knee. It's nothing really special. So these are the lesions. As you can see, they happen in both feet and both hands as well. So we can see both characteristic psoriasis squamate, and we can also see postural lesions that happen on an erythematous background. These lesions are very painful, therefore the patient could not walk. Also, you can see very important nail involvement. The nail involvement also happened in the hands bilaterally. Also, you can see the erythematous background of there were pustulae there once. And you can see the arthrosis of the hands here. Also, here in the palm, you can see the pustulae much better. Again, the swollen left knee was also there. So, differential diagnosis. First of all, the left knee would lead us to think maybe of a septic arthritis, but this would not account for the multiple arthritis locations. Crystalline arthropathy is also an option, but then again, it is so gout or pseudo gout. They usually happen in larger joints, so not in the joints of the hands. Reactive arthritis, psoriatic arthritis, and maybe even rheumatoid arthritis are top contenders for our differential diagnosis. And as I said, haloposa acrodermatitis, which, spoiler alert, this patient had, is a subtype of psoriatic arthritis. So in lab findings, I'll go for this really quickly. So we can basically see an erythrocyte sedimentation rate that's really high. It's the first one there. Sorry, they're not translated. Yeah, we can see a very important, also the C-reactive protein is very elevated. We can see a very important inflammatory, very important acute inflammation. Also, the white blood cell count is slightly elevated. We can see a reactive platelet, so thrombocytosis. And also procalcitonin is very high, but there was a hemoculture done, so we can also make sure that it was no sepsis. It was due to the very important inflammation. Also, so rheumatoid factor, the anti-CCP antibodies, and the anti-nuclear antibodies were all negative, so we can basically rule out other collagenoses such as rheumatoid arthritis or lupus. And the patient was also tested for hepatitis, HIV, and syphilis, all negative. And we can see the modified HLA-B27 antigen. So therefore, we can think of a spondyloarthropathy, but now we have to think which one it is. A PCR of multiple bodily secretions, including urine, was performed, and in urine we found a urinary infection with Mycoplasma hominis. Upon synovial fluid examination of the left knee, we found many neutrophils, no crystals, and no bacteria. So this will lead us to think that it's an inflammatory, it's an acute arthritis, but it's not a microcrystalline arthritis or a septic arthritis. Upon radiological imaging, the only really relevant thing we found was the bilateral sacroiliitis. It was a grade 2 sacroiliitis, so here it is. Here we can see the erosions of the sacroilial joint. I can't really show you, I think you can see them. We can see subchondral sclerosis and also the joint facets that are very uneven. And upon the skin lesion biopsy for psoriasis is not a very common thing to do, but in this case it was performed because there were multiple differential diagnoses and we have to make sure it was actually a form of psoriasis, so we can start a proper treatment. And the skin lesion biopsy confirmed a typical presentation of psoriasis. So before we start delving into the differential diagnosis, I wanted to say that halopozacral dermatitis has a specific treatment, psoriasis has also a specific treatment, and therefore differential diagnosis in this case was very crucial because he present, as you can see here, symptoms of many different spondyloarthropathies. So, first of all, positive HLA-B27 sacroiliitis that was bilateral and asymmetrical joint involvement all raised the suspicion of a spondyloarthropathy. These are the common facts. Palmoplantar psoriasis, so PPPP, is supported by the skin lesion biopsy that was positive, also by the squame, but this can also happen in halopozacral dermatitis, being a specific type of psoriasis. Reactive arthritis is only supported by a recent urinary tract infection. So ankylosing spondylitis only supported by symmetrical sacroiliitis, although all spondyloarthropathies have a certain degree of sacroiliitis. And acrodermatitis halopo is supported by the skin lesions you saw just before, by the very important nail involvement that also led to an onychia of the patient, so the patient lost some of his nails, and the lesions that only happened distally. And as I said, these are classification criteria. So we have to go off the most probable diagnosis. We can't just say it's clearly this and not that because we have no proper clinical criteria. And yeah, so the physicians decided that the actual diagnosis was acrodermatitis halopo. And therefore, the systemic so that treatment was started with methylprednisolone, IV first in acute, and then oral prednisone, betamethasone in the joint of the knee. Also, proton pump inhibitors and painkillers were used as adjuvant therapy. Clobetasol was used locally for the skin lesions, so they wouldn't get infected, and also to treat the pain, so symptomatically. And then chronically, due to the fact that the patient, first of all, had very important function loss in both hands and feet, the symptoms were very severe and they were progressing rapidly. And also due to the very important joint involvement, a very aggressive therapy was started right away. So disease-modifying anti-rheumatic drugs were used, 2 of them specifically, methotrexate with the folic acid folic acid prophylaxis, and also cyclosporine. Doxycycline was used to treat the urinary tract infection, and ixekizumab was used as a biological agent. Ixekizumab is a monoclonal antibody that specifically inhibits the interleukin 17. And also as adjuvant therapy and as prophylaxis, calcium, vitamin D, and proton pump inhibitors were used due to the fact that the patient was receiving very high doses of glucocorticosteroids. And the results, so the treatment fortunately was correct. So the classification for this disease as acrodermatitis halopo was good. It was yeah, so the thought process was a good one on the part of the physicians. And yeah, we can still see that the nail involvement is still there, but the patient is obviously in much better shape. He could walk again, and yeah, the pain was basically non-existent after having followed treatment. So yeah, these are my references, and thanks for your attention. Any questions? No? Okay.
So, this brings the 2025 free paper session to an end. As the free papers coordinator, I can proudly say that this year we had a total of 26 students presenting who visited us here today, not only from Cyprus, but also from other European institutions, such as universities from Romania and Poland. This year, medical students managed to discuss a wide variety of topics and shared new and interesting insights in order to present to us new promising and future treatment methods. So, from novel surgical interventions to the involvement of AI within the field of medicine and 3D bioprinting, all of the presentations here today had one single thing in common, and that was improving patient health. Thank you all very much for making this session so special, and see you all next year.